and signs of scar rupture that you would look for? Could you elaborate?
Ma'am, yes, ma'am. First, on the mother, if there is any maternal tachycardia, there is hypotension or shock which is out of proportion due to vaginal bleeding, there is a loss of station, there is loss of uterine contour, and there is sudden cessation of the uterine contraction. There is there are CTG changes, which is tachy and variable deceleration, late deceleration leading to bradycardia. And also if there is a hematuria and the fetal parts are palpable on abdominal examination. So the patient was stable, and because the patient was stable, we took consent for TOLAC, and we offered her all this.
So what would be the symptoms of an imminent rupture? Like this, you have given me most of the signs of, almost a rupture uterus. But what could be the symptoms of an imminent rupture?
Ma'am, there will be...
Or a scar dehiscence.
Ma'am, there is sudden cessation of the uterine contraction. The patient will suddenly feel that there is no uterine contraction, there is no pain at all. So that means the scar has given away.
She has come in early labor and there may be some symptoms which would make you think of, is she having some sort of a scar dehiscence?
Maternal tachycardia is one of the symptoms.
No, those are the signs. I'm asking of the symptoms.
Okay.
What would the patient, for example, make you think that this patient is complaining of these things, and it could be she's having scar dehiscence or some sort of a thinning out of the scar?
Severe constant abdominal pain.
What are the symptoms they would tell you?
Ma'am, there will be a severe constant abdominal pain before the rupture.
No. Before that, they will complain of constant lower abdominal pain, not very severe, but they will also complain of frequency of micturition. Yeah, there's one thing which is quite significant. They will tell you that we are going frequently to the toilet. That should make you think that probably, and something pressing and something just sort of a pricking sensation. Because once they rupture, yes, you see all these loss of fetal movements, loss of contractions, abnormal shape and all that. But there are most of them, before you take them for TOLAC, you have to assess the scar. No, they wouldn't have ruptured yet. It has not yet ruptured. So in the ultrasound, in a previous LSCS, what are the factors you would ask your radiologist? What are the significant points specifically you would ask for when you ask for an ultrasound in the 3rd trimester for a lady who has had a previous cesarean?
We'll ask the radiologist for the to rule out placenta accreta for the patient. We have to specifically ask for the retroplacental zone of the patient. If there is any abnormality in the placenta, like placental lakes or loss of retroplacental zone, we would also ask for the scar thickness. Although there is no consensus on a particular cutoff for scar thickness, but it has been found in certain randomized trial that a scar thickness of 3.5 mm and above decreases the chance of scar rupture.
Yeah, so you have to specifically ask for this loss of the retroplacental zone and the vascularity, because that's a very important. What is the risk or the percentage of risk of PAS syndrome in previous LSCS?
Yes, ma'am, if it is only previous LSCS without Previa, then there is a risk of, for 2 previous LSCS, it is 0.3%, which can range up to 6.7% in a section, in 5 or more cesarean section. And if it is associated with Previa, then this increases further to 11% for 2 section to up to 67% for 5 or more section.
Yeah. So this
I'll
is
ask a question here.
Yes, madam. Yes, madam.
I'm Dr. Nalini Arora. My question to the students, to the trainees who are presenting the cases, that you have elaborated a very good history and examination. But what are the extra things, if you get a information, will be very helpful in counseling this patient? What are the information you would like to ask from the patient? Or if you, every time you may not get that information, but in case you get it, that will add to your counseling part.
Ma'am, one of the thing is how the uterus has been closed in previous cesarean. which we usually don't get on our discharge paper. But it has been found that if the uterus is closed in double layer, then it decreases the risk of scar rupture. And if it is in single layer, then it has been found that it increases the risk of rupture up to 7-fold.
Anything else?
Ma'am, other than that, the type of uterine scar in the previous pregnancy, if it is possible, we can elicit from the previous discharges, or
Yeah.
the type of
So what
uterine
is that?
incision.
Elaborate on it.
Ma'am, whether it is a lower transverse incision or it is a classical or T-shaped incision, what kind of incision has been given? Because it again affects the incidence of scar rupture in the further
So the
pregnancy.
classical is out. Probably you
Yes,
must
ma'am.
have ruled out in the history. So
Yes,
in the
ma'am.
lower uterine segment, you mentioned T-shaped. What are the
Yes,
other
ma'am.
incisions?
Ma'am, it could be a
T-shaped, low
T-shaped
vertical.
incision,
Okay.
low vertical, and it can be a
J-shape.
J-shape.
So what is your opinion about if you happen to get the discharge slip, a good or operation notes are there, which should be there, how it will affect your counseling to the patient?
Ma'am, we can tell her about we can make her aware about the rate of rupture which she will have in this pregnancy according to the prior incision, because it has been seen that if the most common that we give is a low transverse incision. So if patient is a previous one cesarean, the chance of rupture is 0.2 to 0.9%. If she has multiple low transverse, if it is 2, the chance of rupture is 0.9 to 1.8. If it is a low vertical, it is 1 to 7. If it is T-shaped, it is 4 to 9. If it is classical, it is 2 to 9%. Other than that, if she has a history of myomectomy or any other uterine surgeries,
Okay, let us restrict to the cesarean scar only.
Okay.
So
Okay, ma'am.
in nutshell, if it is
Hmm.
J-shaped, T-shaped, or if there is any extension or low vertical, there is not very vast data available for any standard recommendation, but
Yes, ma'am.
definitely it increases the risk of rupture, intrapartum uterine rupture. And
Yes, ma'am.
accordingly, you have to counsel and take decision. So your history taking should be very, very more refined. And if you get this information, you add, and if you don't get such information, you add a negative point and no such operative details are available with the patient. No prior records are available mentioning about the kind of incision on the uterus. Okay, anything else in the history which can tell you about the integrity of the scar, which can make you more sure that yes, you can take this patient for VBAC?
Ma'am,
Ma'am, any history of extension or need for ligation of vessels in intra period, again, that indicates that that leads to poor scar healing, and that can again affect the present pregnancy.
Okay, what else? What are the factors which make you calculate that yes, this scar is likely to be more sound, more better? May not be absolute percentage you can give it to the patient, but
Yes,
definitely you are.
post-op
infections.
Ma'am, any post-op events we could elicit, like if the patient is having post-op fever with
Definitely, any post-operative complication which points toward the infection. So it might have
surgical
infected
site
the
infection.
scar and deep scar.
infection.
So this is one. This you probably mentioned also in your history. Anything else?
Ma'am. Yes, ma'am. Yes, ma'am.
Ma'am, other than that, the inter-pregnancy interval we have to take into consideration.
So what is the inter-pregnancy interval?
Ma'am, optimum is 18 months. At least more than equal to 18 months should be the gap between two inter-pregnancy interval.
It is inter-delivery interval what you are talking is. So it has
Yes,
to
ma'am.
be
Inter-delivery interval is 18 months.
18 months. What else you have to see in the history? What else you can ask?
Spontaneously.
Whether the cesarean was done in second stage or not, whether the patient has gone into labor and it was a cesarean indicated for second stage arrest, because again that increases the chance of poor healing and increases the risk of rupture in the present.
So indication of cesarean section. Okay,
yes, ma'am.
Whether it is elective or emergency. If elective or emergency, whatever it is, preterm or term. If it is preterm cesarean section, then it is more likely to be better scar or poor scar.
If it is preterm, ma'am, then that is poor scarring because upper
Why?
segment will be involved. Ma'am, because upper segment, the incision will be more towards the upper segment, and upper segment acts as the it in the present pregnancy will be contractile pacemaker of the
So
uterus.
thicker. Lower
So
segment
it
is
is
not
yes,
formed.
and it is
Okay, fine. So the healing will be not that sound, and the
yes.
scar will be higher up. Anything
Yes.
else you can think of?
Spontaneous people indication.
So in your patient, it was emergency cesarean section. It was
Yes,
at
ma'am.
term, but it was
Yes.
emergency.
Yes,
Any
ma'am.
operation notes were available or not? You have not mentioned. Okay, so lower segment must have been formed, well formed in this case,
Yes, ma'am.
because she was already in labor, isn't it? Okay, fine. So any history of multiple blood transfusion, intra-op or post-op, you have already
No,
mentioned
ma'am,
in
no,
the
ma'am.
history. So these are the indirect evidences which can tell you that yes, you can go ahead with your VBAC, or you may have to be little more decisive, more indecisive. Okay, next. So now your patient is in labor, isn't it? Please help me.
May I come in? May I come in? There's one question that I will ask, like to ask Dr. Pragya.
Yes, ma'am.
In your history, there's another point. You said the history of DNC. Is it of any significance?
Yes,
Yes,
ma'am.
ma'am.
Yes, ma'am. Ma'am, any uterine intervention, any endometrial intervention can lead to abnormal placentation and can also lead to placenta ectreta spectrum.
That you will rule out by doing a scan. Would you
Yes,
like to
ma'am.
see the notes? I mean, the previous teacher panelist also asked you, did you review the notes? So would you like to review the notes of DNC?
Notes. What DNC?
See, it's important to review the notes of previous cesarean as well as any other uterine intervention, including DNC. Why?
Yes. Yes, ma'am, ma'am, you are
Yes,
audible.
ma'am. Yes, ma'am. You're audible.
Madam is asking you why do you need to review?
Or DNC. Suppose there's the notes documented there is a perforation, then
That can
Yeah,
lead to
any
weakening of that area.
So that will be an additional risk factor.
Risk
Okay.
factor for
So
rupture.
basically, you need to always access the previous operative or whatever records, medical records are there with the patient. This is very, very essential. And we keep on stressing this in our own college, and I will stress it here again because that gives you a lot of information about your future pregnancy management. Okay.
Okay, ma'am.
Okay, was this patient a book patient of yours or was she unbooked?
Ma'am, she was a
book, ma'am.
book case.
She was booked. So whenever a patient with previous history of cesarean comes to you in your antenatal clinic, you should have some sort of a checklist as to what all you are going to ask. Would you like to include some points now after this discussion?
Yes, ma'am. If a patient with a previous cesarean comes to us, first we'll ask her that what was the reason for her previous cesarean, and what was the baby weight, what was the indication if she knows it, and at what center it was done, because it has been seen that even when it is done at when we open the abdomen for the second time, it is we are prepared according to that, we'll find any additions or not, and if she has received any blood transfusions, and if the neonate had any NICU admissions or there was any complication in the surgeries. And
See, I will just summarize since the time is not less. You would like to know when was the previous cesarean done? How many previous cesarean does she have? What was the indication? What was it, a recurring indication? Was it a non-recurring indication? Whether it was an emergency or a planned cesarean? Of course, where it was done. Access the notes to look for what was the type of incision, what was the sort of suturing, were any intrapartum complications. Review the post-op course. Was there any endometritis, fever? All right. So all
Yes,
these
ma'am.
points have to be documented right during the antenatal period, and the plan for delivery either a trial of labor or an elective cesarean has to be made in the antenatal period itself.
Antenatal period, yes, ma'am.
And this lady lands up at 36 weeks in labor pains in your center, there is not much confusion apart from the new factors that may be arising at this point of time. All right.
Yes, ma'am.
So this is what I wanted to say. Now that your patient is in labor, you said she's in early labor.
Yes, ma'am.
Right. So how will you monitor her labor? You have decided that you have done what is the validity of the scoring that you have done?
Ma'am, we have done phlegms score.
All textbooks are recommending that such sort of a scoring should be done to decide whether or not to give a trial of labor.
Success of TOLAC.
For success of TOLAC, ma'am, we have done the phlegm and Geiger scoring for this patient.
What I'm asking is it routinely recommended that we should be doing a scoring?
No, ma'am.
Are your textbooks, say Williams or any textbook?
No,
ma'am. It has not been a consensus to use any scoring system.
Yes, this is the point that I want everybody to know.
Yes,
there is no universal acceptance of such scorings. So don't get hazard that we don't do this. Use your routine common sense and common routine points in the history and all the examination that we have just discussed. So this all these points have to. Now this patient is in labor. How will you monitor her labor in your center?
Ma'am,
vaginally.
Yes. We have taken the consent from the patient and we have properly explained her about the risk and benefits of the procedure which we are going to do. We have arranged blood and we have done blood cross matching and we have arranged blood products. We have put access a IV line and we have started the monitoring of the patient as well as fetal monitoring. For patient monitoring, we'll do the pulse rate monitoring and scar tenderness monitoring for every 15 minutes in first stage. And BP monitoring every 30 minutes, and we'll do the CTG continuous NST monitoring or CTG monitoring.
Scar tenderness every 15 minutes.
Ma'am, in first
actually do it?
Ideally, we don't do it, but it has been written in the...
See, what is the expected duration of this lady's labor at this particular point of time?
4 to 6 hours. 6 to 8 hours.
So 8 hours and for 8 into 4, 32 times you are going to check for a scar tenderness?
Yeah, ideally we don't do it like this.
So please think of something which we routinely do. So why are you doing for scar tenderness? How reliable is your checking for scar tenderness? Is it the most reliable finding which tells you about the scar giving away?
No, ma'am. There can be conditions in which we...
What will be the earliest indication that the scar is giving you?
Ma'am, CTG changes which we get.
CTG changes. So
yes,
more reliable than that scar palpation is this scar CTG changes, right?
Yes, ma'am. Yes, ma'am.
What else? What else? Pulse rate,
maternal tachycardia, ma'am.
And maternal hypotension.
Maternal hypotension, yes. And what?
Any abnormal bleeding.
We come back to what we discussed right in the beginning with your other examiners, right in the beginning. If patient is in labor, she is having contractions.
Yes.
So what are the other signs that will tell you that patient is probably the scar is giving way? Just a quick recap.
Yes, ma'am. There will be patient will have sudden cessation of uterine contraction. There can be loss of uterine contour. There can be loss of station. And we can have any abnormal or severe vaginal bleeding.
That you will get to know when you palpate the patient.
Yes, ma'am.
But probably the symptom, you will see the vaginal bleeding coming. Unexpected
vaginal bleeding.
Yes.
And there can be hematuria also.
Yes. So these are the signs. So this is one if the scar rupture. Now suppose the scar is not rupturing and everything is progressing fine. And you find there is a slow labor. So would you like to augment her?
Yes, ma'am. We can augment. Ma'am, we can augment the labor for the patient, but we have to be cautious to use a low dose of oxytocin as compared to what we use in normal routinely.
So what would be the...
I'll just sorry, you can carry on.
Yeah.
I just want
So,
to ask
Dr. Pragya, you said what would be the indications for you to think of augmenting the labor?
Ma'am, if the second
stages. She is 3 centimeters, she is getting contractions, and okay, we are watching. And when will you think I need to augment this patient?
Ma'am, if there is a spontaneous rupture of membrane, and if the patient is not progressing.
What is this progress? What do you mean by not progressing?
Dilatation 1 centimeter.
Ma'am, we'll draw the partograph for the patient, and on the partograph or labor care guide, we'll look for the patient progress of labor. And if it is something away from normal, then we have to augment the labor.
So according to the new WHO labor care guidelines, when do you think that the patient would be classify her as being an active labor?
After 5 centimeter, ma'am.
Yeah, so you have to. So she's now you see that she's just 3 centimeters.
Yes,
so
ma'am.
Till then, how are you going to look after her? You're not going to augment her now, are you?
No, ma'am.
Yes. So how are you going to monitor her? Or you may not be there. And what are the instructions you will give to the person, the attendant accompanying the person?
Ma'am, we'll ask the patient to take liquid diets, and we'll ask her not to take any solid diet. We'll ask...
and we'll do her pulse rate monitoring, her BP monitoring every 15 minutes. We'll look for any signs and symptoms of any scar rupture. And since we are giving her TOLAC has to be given in a center which has continuous CTG monitoring. So we will do her continuous NST, and we look for any changes in the NST, in the fetal heart rate. And other than that, we look for any severe vaginal bleeding, and we look for hematuria. And if the patient suddenly complains of there is a cessation of her uterine contractions, and
if the patient asks for pain management,
what is the most common time when the scar rupture occurs in a
woman? Ma'am, it is during active labor, when patient is 4 to 5 centimeter, and it has been found that in second stage it is approximately 18% risk of scar rupture, and immediate post delivery period it is 8%.
So the most likely chance is in the second stage when lot of activity is happening, and in the immediate postpartum. So in second stage, you are there with the patient, and you know about the signs and symptoms, and you will pick up. You just told us about immediately after delivery scar rupture. So how will that case present like?
Ma'am, patient
postpartum
there will be abnormal vaginal bleeding in spite of adequate uterine contraction. Patient will have massive bleeding, and there will be hypotension, shock, and there will be hematuria.
And even after giving oxytocin, she will not bleeding will not stop.
So unexplained maternal collapse happening, postpartum collapse, one has to think of a scar rupture.
Scar rupture, yes.
Now you tell me, when we talk of rupture, there are two terms, scar rupture and scar dehiscence. What do you understand by the two terms?
Ma'am, in scar dehiscence, only the myometrium gives away, the fetal membrane and serosa is intact. Whereas in rupture, all the 3 layers have given out. And
okay, we are talking so much about rupture, the scar rupture in labor. Now my question is, if the patient is... Hello, am I audible?
Yes, ma'am.
There's some disturbance. There is some disturbance. Yeah, now you're on.
So we are talking so much about the scar rupture and all. My question is, if all this happens in the labor, and if the patient is not well informed or mentally prepared to have such a complication which may arise suddenly, so that will be a very big disaster. So you all have said that you have taken a consent. So one thing is that it has to be informed consent. I hope you know the difference between consent and informed consent. And what all have you counseled? Like Dr. Dipti has said that it has to be decided in the antenatal period. So whatever, whether you talk to the patient and the couple in the antenatal period or during early labor, So what all have you counseled so that she is prepared if this all happens in spite of all good precautions, the scar ruptures, then you have to have people should be very much aware and well prepared to face that emergency. So how have you counseled? Tell me. Counsel your patient. What all information you have told to the patient and the family?
Yes, ma'am. We'll tell the patients that since she's going for this procedure, she, of course, with her baby will be affected by it. So we will explain her the maternal outcome and the fetal outcome. So we'll tell her that as she is going for vaginal delivery, we'll compare it with an elective cesarean section, and we'll tell her that the vaginal delivery has a success rate of about 85 to 90%. And
It's
has
70
an
to 75%, I think.
70 to 75%.
If she has previous vaginal delivery, VBAC, then it is 85 to 90%.
Okay, carry on.
The second thing that we'll tell her that, of course, we'll inform her about the chances of scar rupture, like we have told her, and we'll tell her that if there is scar rupture, she will have to be taken up for an emergency LSCS, and that will ultimately include the need for blood transfusion, the need for
Okay, then
ICU
what else?
stay,
What else?
the chances of hysterectomy, if there is a lot of blood loss and uncontrollable blood loss, that she can end up in SSI.
So
And
what else?
other
If you
than that,
keep on telling her all this, she'll run away from the VBAC. She'll say, no, I want cesarean section. So
And have
there
you
has
told
to
her
be a
if this
method.
happens, she
There
will
has
lose
to
a
be a
baby?
list. There should be a proper information
Ma'am,
you
we
will
have
tell
to
your
tell the
we have to
patient
tell the
in a
patient
positive
way.
reinforcement way that although these are the risks, but the risk of rupture is 1 in 200,
1 in
which comes
200.
out to be 0.5% only. And the risk of perinatal outcome is 3 in, if there is risk of HI, it's only 0.8%. If there is risk of any perinatal stillbirth, it is only 0.5%. So in this percentage, we'll explain the patient and we'll try to
This she
counsel
won't
her.
understand. What else you have to tell her? For her, even 0.51% may be very high. She'll say, no. Who is that 1 out of 100? I don't know. It may be me only, na? So what else you have to tell her when you're
Repeated
counseling?
cesarean section can lead to complications in further pregnancy, and she can have other complications like abnormal placentation, placenta equita spectrum
Okay,
in further
fine. Anything
pregnancy.
else you will tell her? So with the
Ma'am, we'll
alternatives,
also tell
you
her
have
that
to tell what are the alternatives. So in informed consent, you have to tell this is the procedure, these are the risks, these are the alternatives. What are the risks of the alternatives? Then only the patient can take a decision. So go ahead. What else you will tell her? Hello?
Yes,
Yes,
ma'am. Yes,
yes.
ma'am.
Yeah, what
Yes.
else you will tell
Yes.
her? So one is that if she'll have a cesarean section, then
Yes,
she'll
ma'am.
be likely to have repeats again cesarean. She'll likely to have what else? With the
Abnormal placentations.
okay,
Also,
what
ma'am,
else?
if she goes for a VBAC, like TOLAC, she'll have a normal vaginal delivery, which will result
increase
in
the
shorter hospital stay, early recovery.
Okay,
and
what
there are
else?
increased chance of vaginal
Okay,
birth in the future.
what are the risks to cesarean in this patient? Now, what else risks are there? But if she opts for cesarean, then what are the extra risks she may have, which she may not have in VBAC?
Ma'am, she can have a bladder and bowel injury.
And hysterectomy.
Have to be
Anesthesia
there
risk.
in both the cases. Okay, tell
The
us something
anesthesia
very
risk.
positive. What will happen to the baby if she has
Ma'am, there
elective
will be
cesarean?
higher chance of transient tachypnea of newborn in ERCS.
Yes, that you have to tell. Okay,
Yes, ma'am.
so how you can do that? In case you have cesarean elective, though this is not applicable to this patient because she's already in labor, but she's at 36 weeks, but she's in labor. What can be done antenatally to reduce that transient tachypnea of newborn?
Ma'am, according to RCOG, it has been indicated that any patient we are taking for cesarean section up to 39 weeks, we can give corticosteroids
before delivery.
Okay, so you will give corticosteroid that will lessen, but that will reduce, but that will not remove total risk of.
Yes.
Yeah. So what are the other things you will tell her in the counseling? So you will tell that what is her chance of having a vaginal delivery in VBAC. That is, what are the risks with the VBAC? What are the risks with the cesarean section? What are the risks to the mother? What is the risk to the baby? what are the risks in the future pregnancy, and whatever risk she has in this thing and VBAC is very much comparable to the spontaneous delivery in a non-scarred uterus, whatever risk for the baby she has here, isn't it?
Yes,
So
yes,
that
ma'am.
consent part, that counseling part has to be very proper. It has to be endorsed, to be notified in the patient's record, and then you can go ahead. Okay. So now we come back to the labor part. Now she's mentally prepared for all this disaster which may happen, and probably it will not happen, but it has happened. So now we will proceed with this, whatever questions were
I want to ask you, since the time limit is also there,
Yes,
I want to ask about how will you manage previous cesarean with twin pregnancy with no other complications? And she has come to you at 36 weeks in antenatal OPD. How will you plan for her delivery?
Ma'am, according to the recent guidelines, it has been found that previous cesarean with twin pregnancy, if we give a trial of labor, the risk is comparable to a singleton pregnancy. So if the first baby is in cephalic, then we can give her a trial of labor if all other criteria are fulfilled.
All right. Another question is, what is the role of induction of labor? In what all scenario you may like to induce labor in a patient with previous cesarean?
Ma'am, we can...
yes.
Okay. Yes, ma'am. Sorry, ma'am.
Please go ahead.
Okay. Ma'am, we can give induction of labor in a patient with previous cesarean section, and the methods are accordingly. We can go for mechanical method followed by prostaglandins and oxytocin. The best method is...
What prostaglandins are you talking about?
Ma'am, prostaglandin, dinoproston, one dinoproston gel is allowed to give according to RCOG and ACOG, and misoprostol is contraindicated. Foley's induction is the best induction in patient with previous LSCS, and it has the scar rupture rate of 0.7%, which is comparable to the spontaneous labor. And with prostaglandins, the risk of scar rupture is 2.9%.
Around 3%.
Yeah, around 3%. And with oxytocin, it is 1.2%, which is again comparable to a patient coming in spontaneous labor with previous section.
Okay, you tell me, a woman comes at 36 week previous cesarean singleton pregnancy with leaking, absent membranes. Now, how will you proceed?
Ma'am, first we'll see the bishop of the patient. We'll do a we'll rule out any sign and symptoms of chorioamnionitis. Then we'll see her what is the bishop of the patient. If the bishop is more than 6, we'll go for augmentation of labor. And in augmentation, we'll use a low dose indocinon, which is 2.5 milli international unit per ml, and we can go up to 20 milli international unit, not more than that, because it has been found that more than that, if we use, there is increased risk of scar rupture. And if the bishop is poor, if it is less than 6, then we can...
Recommendations about the dose of oxytocin which can be safely used for induction, up to what dose? Do the guidelines talk about the symptom, how much of oxytocin can be given?
20. Yes, ma'am. It is written that in randomized control trial, it has been found that if we use more than 22 milli international unit per ml, there is increased risk of scar rupture.
What about a non-scarred uterus? In a non-scarred uterus, till how many milliunits per minute would you like to go? It is milliunits per minute. It is not per ml.
Yeah, ma'am, milliunits. 462.
Basically, it's not hugely different from how you would augment the non-scarred uterus, is it? You got to exercise caution, because guidelines don't talk about how much is the upper limit of the oxytocin.
20 milliunits.
20.
All right.
Ideally, not more than 20 milliunits.
So whatever you must be having some SOPs or your protocols, you have to stick to it. And remember, the chances of rupture will increase with oxytocin as compared to the Foley's, and with misoprostol, of course, they are much more, and that is why that is contraindicated.
Contraindicated.
All right. So now this patient has delivered.
Yes, ma'am.
Your scoring was correct. You did a very good intrapartum care for her. Yes, she delivered, healthy mother, healthy baby. Now, what is the part of now care that you would like to give to her?
Ma'am, in postpartum period also, we have to observe the patient at least for 4 hours for any sign and symptoms of scar rupture and any postpartum hemorrhage.
Anything else? Proceed further. First day is gone. You are writing a discharge for her after 48 hours. What else you should discuss with her?
Contraception, ma'am.
Yes.
Yes, very
Very
important.
important. So, ma'am, if since
Can't
this
let
patient
go away without contraception.
no, ma'am, we don't send patient without
So
contraception.
what are the options? What are the options you have for her?
Ma'am, since this patient has delivered, normal delivery has been done, so we can go with IUCD, intrauterine copper device, or we can also go for implant for the patient.
So when will you actually talk to the woman, the couple about
antenatal, ma'am, during antenatal period.
So do you have a checklist that you talk to them when you're talking to them about the VBAC and or whether it's VBAC or the cesarean?
Yes.
So before that, I just want to ask you, yes, the patient is fully dilated now. She's in labor, everything is going on fine. And how will you conduct the delivery, the second stage of labor? What modalities would you use and how would you go about delivering the woman? Any special precautions or any assistance what would you like to do for her?
Ma'am, we don't give fundal pressure in a patient with previous cesarean. We do not use
in any patient. In any patient.
No, with any patient for that.
Try to avoid that in all patients.
Yes,
ma'am. Yes. Then?
And ma'am, if the second stage is prolonged, if it is ideally if it is more than 1 hour, then we can cut short the second stage of the labor by using instruments. We can use forceps or outlet forceps or vacuum for the patient.
So what are the criteria for an outlet forceps?
Completely dilated. And the patient should be completely fully dilated, ma'am. The head should be rotated up to 45, more than 45 degree, and station should be plus.
Yes. What should the station be?
+2 or more than +2.
Yeah, because it's outlet, right?
Okay, outlet is +2, +4 because outlet means the head is visible and not receding, in the contraction and visible without parting the labia, and it has to be +3 and above. +2 is low cavity, which is probably not indicated in this case if everything else is fine, fetal heart is fine. So that has to be taken care of.
So ideally, the forceps. You are in a tertiary care center, and all residents are on duty, and the patient is fully dilated. Would it be who would you like to have deliver this woman by forceps?
Ma'am, ideally a senior resident.
Yes, very important. It has to be a senior consultant who should be handling a VBAC. Okay, then you have done the forceps. What would you prefer? Advantage, forceps or the vacuum?
Depending on maternal and fetal condition.
Yeah. So what are the pros and cons of using the forceps or using the?
Ma'am, with forceps there is increased risk of fetal injuries, and also.
So basically, it's in what the SOPs are there in your institute. Which is not that forceps is better scores over. Of course, there are pros and cons.
It depends on the skill of the
exactly, and the training that you have undergone. Yes. So you can. Okay, you have delivered her by forceps now. You have delivered her by forceps. So then what? How are you going to manage the next third stage?
Ma'am, we'll do the active management of third stage of labor.
What is that?
Ma'am, that is giving immediate uterotonics after delivery of the fetus. Then we have to do control cord traction and delayed cord clamping.
And
uterine massage.
Uterine massage, right? Okay, patient has delivered the placenta, but still you see there's bleeding. So what else are you going to do? Just deliver the placenta, inspect the placenta, and are you done with it? Are you done with that? What would you do?
Ma'am, we'll check for uterine.
To sleep well.
Ma'am, we'll see for the uterine contraction and we'll see any abnormal vaginal bleeding, and we have to see if the patient is bleeding in spite of giving oxytocin or adequate uterine contraction, and will not this thing explore the uterus of this patient who is having previous cesarean section if there is no any sign and symptoms of scar rupture.
So you've done a forceps. So ideally, you should have a good light source, good retractors.
For any
Not
local
only,
trauma.
inspect the vagina for any
Local
cause of
laceration.
traumatic PPH also has to be ruled out. So it need not be just rupture of the uterus. It could be even just a cervical tear or a vaginal abrasion, laceration. And what would be your take on an episiotomy for this lady?
Yes, ma'am. Liberal episiotomy.
If we are using instrument, ma'am, we have to give a liberal episiotomy
to prevent any anal sphincter injury.
Yeah. So otherwise, of course, if it's a small baby and you feel that the baby is going to, would you still give her an episiotomy?
Yes.
She has not had a vaginal delivery. She's only had a cesarean delivery previously. So what is your SOP on a routine episiotomy? Is it required?
No, ma'am, routine episiotomy is not required. But since we are using instrument to prevent perineal injury, we have to give episiotomy.
Okay. So, well, this patient is in second stage of labor. She's not progressing, and suddenly you see there's hypotension, there's tachycardia, and what will you do? And you feel that there's a dehiscence or a rupture.
Ma'am, we have to take the patient immediately for cesarean section. We have to perform category 1 cesarean section. Ideally,
so have you informed? When do you inform your operative team, your OT?
Ma'am, we keep on check. We inform all the senior obstetrician, anesthetist, and OT staff,
and the pediatrician
also that we are dealing with TOLAC, and anytime we can need a cesarean for the patient. And
that's very important. So even before you start the VBAC, even when she comes in labor, they need to be notified that there is a patient who is in VBAC, and they have to be available round the clock, isn't it?
Yes, ma'am. Yes, ma'am.
Fine. So yes, you rush her to the operation theatre. So what are the what complications could you have on table? So how would you deliver her? What type of incision? What type of anesthesia? What would you like to do?
We'll go with a if patient is stable, ma'am, then we will go with epidural.
She's not stable. I just told you she's not stable. She's ruptured her uterus. She's ruptured her uterus.
We'll give GA because we don't have so much time, not for the mother, especially not for the baby also. So we'll go with the GA and we'll perform cesarean section ideally as early as possible or within 17 minutes of the diagnosis of scar rupture. And we'll give So
what would you anticipate on the table? Like, what are the complications you could anticipate? So you have to go in as quickly as possible, right?
Yes, ma'am.
So what on table?
We have to anticipate intra-abdominal adhesions for this patient. Already she is previous cesarean. There is anticipation of blood loss, so we have to keep
blood arranged. We have to get it arranged.
And, you open the uterus, and of course there's a scar rupture, and the bladder is there's a scar dehiscence. There's a scar dehiscence, and the bladder is also either in there. How are you going to enter the uterus? Where will you put your incision? On the uterine incision.
On the upper segment.
You should go a little higher, yes. Don't waste your time going to separate the bladder and go through the scar which is covered with adhesions. Preferably go higher up.
Okay. Yes, ma'am.
So would you advise a PPI-UCD for this woman? She has delivered now. Okay, luckily her VBAC is successful. She has delivered. So what is the success rate of VBAC?
Ma'am, ideally it is 70 to 75%.
Yeah, that's good. 70 to 72%. And okay, then the baby has delivered. What is your breastfeeding protocol for this woman?
Ma'am, the patient... Yes, ma'am. She has to exclusively breastfeed the baby for 6 months. and then along with weaning up to 2 or
When will
2
you
or
start? When will you start the breastfeeding?
Ma'am, immediately after delivery.
Yes, that is what you have to get into the habit of immediately putting the mother to the breast. So in case she undergoes a cesarean,
Yes, ma'am.
payback is not successful, she has a cesarean, then when would you put the baby to the breast?
Ma'am,
we put
then
it
also
immediately,
we
ma'am.
put immediately skin to skin attachment, and breastfeeding is started by the pediatrician, ma'am.
Right. So you have done that, baby breastfeeding, and then the sister, you've gone back to have your coffee, and the attendant calls you back saying that the patient's pulse is 120, BP is 100, follow about 1.5 to 2 hours following the vaginal delivery. What are you going to do now?
Ma'am, first we'll look for the
Any
postpartum hemorrhage and uterine tone, because one reason for this could be postpartum hemorrhage. And then if the tone is okay and still the patient is bleeding, then this could be a
vaginal hematoma. Hematoma.
See, once they've been called, your staff is telling you BP is 100 and pulse is 120, you have to shout for help. You have to put in the PPH protocol, start an IV line, or I mean, she's already having an IV line. Any VBAC, they have to have an IV whiteboard needle. Start another IV line, rush in fluids. So these things have to take place simultaneously. The PPH bundle has to come in immediately before you even try to find out what is the cause of her shock. You have to, one person is,
the patient first.
yes, resuscitate the patient. So don't waste your time just looking and trying to find out why she's bleeding. Meanwhile, while one person is doing that, the other persons, they have to shout for help, get the team ready, rush what crystalloids should be rushed, whiteboard, IV cannula should be put in place, blood should be arranged. And along with that, what you said, you're going to assess what is the cause for her shock.
Cause of the bleeding.
So what could be the causes of shock? What could be the reasons? Her mind should be running, right? What could have happened to her? Everything was fine. She has delivered, and now what happened?
Ma'am, patient is a previous cesarean. So one of the things that we have learned is that the chance of scar rupture in the postpartum period is high. So one of the reasons is postpartum scar rupture. Second is if we have delivered her vaginally and if we have given her any episiotomy, there can be hematoma at the site, or there can be any cervical laceration or cervical tear which was not explored during the vaginal delivery or post the vaginal delivery. So one of the reasons is blood loss, and the second is if there is any thromboembolism.
Yeah. So the first possibility always is hemorrhage.
Interrupt, ma'am. Taking your time for a while.
Yeah, we're done. Yes, yes. You can go ahead. I can request the other examiners to. Well, Dr. Pragya, you have done Pragya, and what's the other girl's name?
Sreeba.
Yeah, Sreeba. Both of you have done well. I would request the other examiners to give their concluding remarks. Congratulations and all the best for your future.
Thank you so much, ma'am.
I think they have done, both of them have done well. Yeah.
So,
I think it's fine, but you need to stress more on the history taking, document details, previous document detail, counseling part, and then of course labor and other management is discussed.
Okay, ma'am.
So thank you so much, Bharti ma'am, Nalini ma'am, and Dipti ma'am. It was a very nice session. Congratulations, Sreeba and Pragya. Now we would like to move on to the next case, which is on multiple pregnancy. For that, I would like to call upon the moderator for the session. First moderator is Dr. Professor Colonel Reema Bhatt ma'am. Ma'am is in Amrita Hospital. She is professor and head of the medicine department and perinatology. Welcome, ma'am. The second moderator we have is Dr. Aparna Sharma ma'am. Aparna Sharma ma'am, she is a professor Obs and Gynae in AIIMS New Delhi, and she is an expert in fetal medicine. And the third moderator for the day is Dr. Sangeeta Gupta ma'am. Ma'am is Director Professor Obs and Gynae in Maulana Azad Medical College, and she's the person who has established a fetal medicine clinic in MAMC and LNJP Hospital. Welcome, ma'am. So, sorry, I think there was some problem with the slide. Dr. Sangeeta Gupta ma'am is professor in SIMS Hapur, ex-HOD Obs and Gynae, ESI, PGMI SAR, Basaidarapur. Welcome, ma'am. And to present the case, I would like to call upon Dr. Payal Hooda and Dr. Maria Haroon. So, can we go ahead with the case?
Yes, ma'am. Good evening, ma'am.
Good evening,
ma'am.
Yes, good evening, good evening.
Please go ahead with the case.
Ma'am, today's case presentation is on the topic multifetal pregnancy. It is presented by me, Dr. Payal Hooda, second year DNB resident, Sir Gangaram Hospital, and Dr. Maria Haroon, first year DNB resident. Our patient is a primary gravida with 36 weeks of period of gestation with IVF conception with DCDA twins with complaint of decreased fetal movements. She presented in twin A. Mrs. X, wife of Mr. Y, she is 39 years old, resident of Karol Bagh, New Delhi. She's her education status is she is 12th standard pass. She is homemaker, belonging to lower middle class family according to Kupuswamy modified Kupuswamy scale. Her this is IVF conception. Her ET embryo transfer was done on date 20th September 2023. It was day 5 embryo transfer. Her EDD was 7th June 2024. And at 36 weeks of period of gestation, she presented. History of presenting illness. Patient came with the complaint of decreased fetal movements in twin A since last 4 hours. There was no history of pain in abdomen, no history of excessive nausea and vomiting, no history of breathlessness, no history of bleeding or leaking per vaginum, and no history of swelling of legs. Obstetric history. She's married since 12 years, non-consanguineous marriage. She's primary gravida. Embryo transfer was done on 20th September 2023 on day 5. EDD is 7th June 2024. At 36 weeks of period of gestation, she presented. First trimester. Sorry, ma'am, there is a printing mistake. This was IVF conception. This was confirmed by UPT at home at 10 days overdue of missed period, registered at a local maternity home at 2.5 months of gestation. Routine blood investigations were done. Patient was started on tablet folic acid and which she took regularly. First ultrasound was done at 11 weeks of gestation, which was suggestive of DCDA twins, and NT-NB was done for both the fetuses, which were normal. Dual marker tested low risk, which reported low risk. Tab ecosprin 150 mg HS was started. There was no history of excessive vomiting, no history of any discharge, bleeding or spotting per vaginum, no history of any increased frequency or burning micturition or fever with rash, no history of easy fatigability, no history of exposure to radiation or drug intake. Routine ANC was done.
Can I interrupt you for a moment?
Yes, ma'am.
I just have a few queries from you. First of all, how could you comment that the decreased fetal movement was because of twin A1? Number two, you have not mentioned whether it is a donor egg or it is a self-egg IVF. She's 39. And third, for a IVF pregnancy, the first scan at 11 weeks, somehow I'm not convinced.
Ma'am, dating scan was also done. NT-NB scan was done at 11 weeks of gestation, and it was donor egg.
All right. So can you figure out how much impact it will have now?
Yes,
if it's
ma'am.
a donor egg? Yeah.
Second trimester, quickening was felt at 5th month of gestation, and she continued perceiving fetal movements. The 2 doses of tetanus vaccine were received. Patient took iron and calcium supplements regularly. Level 2 scan was done, which reported no gross congenital anomaly. GTT was done, which reported normal. In third trimester, she continued perceiving fetal movements, iron calcium taken regularly, no history of pain in abdomen, any bleeding or discharge per vaginum. Patient came with complaint of decrease in fetal movement since last 4 hours. Ultrasound BPS was done for both the twins, which reported score of 8/8 with sluggish movement in fetus in twin A. In menstrual history, she attained menarche at 13 years of age. She had regular periods, which lasted for 3 to 4 days and came every 30 to 35 days. She had average flow. Past history. There is no history of hypertension, diabetes, TB, asthma, epilepsy, and thyroid disorder. No history of blood transfusion in the past. No history of any recent surgery.
Family history, there is no history of twin pregnancy in mother or sisters. Personal history, she had normal appetite, bowel and bladder habits were normal, no history of drug intake, alcohol consumption, and smoking. Her dietary history, on the basis of 24-hour recall method, she was taking mixed diet. She consumes about 2,500 kilocalories per day with 62 grams of protein daily. On general examination, she was sitting comfortably. She was conscious, oriented with time, person, and place. She was averagely built and had average nutrition. General condition was fair. Her height was 156 centimeters. BMI is 22, which was measured according to the pre-pregnancy weight. Her pre-pregnancy weight was 54 kgs, and her present weight when she presented at 36 weeks of gestation was 68 kgs. Weight gain was 14 kgs during pregnancy. Breast examination, no abnormality was detected, and during thyroid examination, no enlargement was detected. Her hydration was adequate. She was afebrile on touch. Pulse rate was 84 per minute in right radial artery with good volume, normal character, no radiofemoral delay. All peripheral pulses were palpable. Her BP was 120 by 80 in right arm in supine position. 1 second. Which was repeated after 15 minutes, and similar findings in left arm were also found. Respiratory rate is 18 per minute, thoraco-abdominal, no pallor, icterus, cyanosis, and clubbing was noted. Bilateral breast examination was normal. Systemic examination, respiratory system, bilateral air entry, no added sounds. And on CVS examination, S1, S2 was heard, no murmur sound was heard. CNS, no abnormality was detected. On per abdominal examination, on inspection.
Dr. Payal, from here I am going to continue.
Yes, ma'am.
Abdominal examination, inspection. Abdomen appears over-distended. Uterus ovoid in longitudinal axis. All quadrants moving well with respiration. Umbilicus central and everted. Linea nigra stria gravidarum seen. No dilated veins. I am unable to go to the next slide.
Just tap in the center. Take the cursor on the center and then now move it.
Yes, ma'am. Palpation. All inspectory finding confirm symphysiopundal height 38 centimeter. Uterus measure 38 weeks size. Relaxed with fullness of flanks. Multiple fetal parts felt. Clinically liquor adequate. First twin is cephalic presentation. Second twin in breech presentation. Fundal grip. Multiple fetal part felt, lateral grip, smooth continuous curve felt on right side, and irregular multiple fetal parts felt on left side. First pelvic grip, hard ballotable mass felt suggestive of head of twin 1. Second pelvic grip, findings of first pelvic grip confirmed, cephalic pole not engaged. Next. Auscultation, 2 fetal heart sounds heard, one in right spino-umbilical line, regular, 138 beats per minute, and second just above umbilicus towards left side, regular, 150 beats per minute. Inspection of vulva, vulva appears normal, no leaking. Per vaginal examination, cervix appears to be short, soft, os closed. Case summary, Mrs. X, 38 years old, primary gravida with 36 weeks POG with IVF conception with dichorionic diamniotic twins with complaint of decreased fetal movement in twin A. Her vitals are normal. Obstetrics examination revealed over-distended abdomen with symphysiopundal height of 38 centimeter. Multiple fetal parts could be palpated. On auscultation, 2 fetal heart sound could be heard at 2 different sites. USG BPS biophysical score done for both the twins reported score of 8/8 with sluggish movement in twin A.
Can we take up the discussion now, or should we wait
Yes,
for
ma'am.
Okay, so my first question to you would be, when you do a ultrasonography in a twin pregnancy, besides what all will you look for?
Ma'am, in first trimester, we will Ma'am, in first trimester scan, we will look for the viability, we will look for the GSAC, we'll do the dating, and we will also label the twins, whether it is right twin, left twin, upper twin, or lower twin. And we will look for the chorionicity, and also at 11 to 13 weeks of gestation, we will measure NT. Of both, in case of DCD twins, both the NTs will be measured, and in case of monochorionic MCD twins, mean NT is measured.
And we had asked you a question whether the eggs are donor eggs or they are self eggs. So what impact does this information have in your case?
Ma'am, in case of during the first trimester screening, there is combined screening, which also includes the age. So in this case, the age of donor will be taken instead of the maternal age, which is 39.
Where does it leave an impact?
Ma'am, in case of the anomalies, in case of PIH screening, ma'am, it will have impact. If in case of donor egg, there will be more chances of having PIH.
Does it have impact on something else before we talk of preeclampsia? You're talking of NT on one side and you're telling me preeclampsia on the other side?
Ma'am, risk of Down
genetic and all.
Ma'am, it will have impact on the screening of Down syndrome. So,
aneuploidy screening.
Aneuploidy screening.
So what is the importance of knowing the chorionicity in a case of twin pregnancy? What is the most important point which we focus is? So you said it is, how you confirm that it is dichorionic, diamniotic twin?
Ma'am, in case, ma'am, there are many ways to determine the chorionicity. One sign is lambda sign, which is taken,
which is the ultrasonography. Yes.
Ultrasound.
Yeah.
Ma'am, in lambda sign, there is triangular projection of the placental tissue in between the membranes. So that suggests the lambda sign, and there are also 4 membranes in between the twins. And the thickness is more than 2 mm. These suggests the twin is dichorionic.
Which is the thickness of the intertwin membrane.
Intertwin membrane.
Intertwin.
And how you confirm that it is
diamniotic twins?
And there are 2 placental membranes.
So how you will say that it is a monozygotic twin, not dizygotic twin?
Ma'am, ma'am, that will not, the zygosity will not be known by ultrasound. If it is monochorionic twin, then it will be always monozygotic. But DCD twins can be monozygotic and dizygotic both.
Yes, that's what I wanted to know. Yes.
Yes, ma'am.
Okay. So what else how you will monitor your patient now? We are just discussing firstly ultrasound. Ultrasound you have done once for this thing for aneuploidy screen. You have done for structural screen. Yes, what else on ultrasound at 11 to 13 plus 6 days? Ultrasound. What you will see? 2 things you have told me.
Ma'am, preeclampsia screening. Uterine artery PI.
Preeclampsia screening is not with ultrasound, beta. It is with biochemical marker.
Yes,
so what you will see on ultrasound while you are doing a scan at 11 to 13 plus 6 days scan. You have seen for NT. Okay, you have seen for structural abnormalities. What other things?
Ma'am, some anomalies like anencephaly can be ruled out.
That I have talked about structural anomaly. What else you will see on the ultrasound when you are doing this ultrasound?
Ma'am, chorionicity will be 11 to 13 weeks is the best time to confirm the chorionicity.
You will see for fetal viability, you will see for age, you will see for fetal growth later on when we do, but at the time also you will confirm the period of gestation, viability of the fetus. Now, how, when they are twins, and how you will confirm the gestational age?
Ma'am, gestational age.
In this case, it is an IVF pregnancy and ET has been done. So yes, you know the density and from that you have calculated. But suppose it is like that, what is the importance of other things which you see at 11 and 13 plus 6 days.
From CRL, ma'am, we see
See for the location of placenta, will you not see for the amniotic? I mean, what are the other things which you can see at this age and then later on in other ultrasounds? So basically, you will say for gestational age and fetal viability. You will see for curiosity. You will see whether it is, which type of twin it is, whatever it is. Then you can also see, anyways, then you will do the serial ultrasound. So suppose you have confirmed your diagnosis on ultrasound, then how you will, what you will advise antenatally to this patient. She has come to you first at 10 weeks or 12 weeks, whatever.
Ma'am, we will advise this patient that as she's having twin pregnancies, so she will require more frequent monitoring. In case of DCDA twins, she will require every 4 weekly ultrasound screening, and in case of MCDA, she will need ultrasound screening 2 weekly.
2 weekly.
Okay, agreed.
And ma'am,
regular we'll ask her to to follow on the hospital regularly, and then additional calorie requirement is also needed in case of multiple pregnancy, which is 100 kilocalorie per day. Then multifetal pregnancy, mother with multifetal pregnancy are more prone for anemia, so we will add supplements accordingly.
Then
ma'am, we will also counsel her.
To preterm labor, then you will advise adequate rest to that patient.
Yes, ma'am.
Okay.
Yes, ma'am.
We will also advise. We will also counsel her about that she is more likely to have some complications like preeclampsia or placenta previa or gestational diabetes or preterm labor or
hyperemesis gravidarum.
Okay. So you are following up this patient in antenatal period. You have she is following your advice now. Thinking that she's a DCDA, she comes to you at 16 weeks. Now, what you will advise?
Ma'am, we will check for the anomaly, and we will check for we'll look for the biometry, amniotic fluid, and we will also check for the anomalies, and we will advise her to follow 4 weekly with us, and also on the Doppler studies, ma'am.
We'll do the Doppler study, umbilical artery, PI, and DVP also, deepest vertical pocket, we'll see.
So now you will see, suppose she's a monochorionic pregnancy. So what all things you will monitor from 16 weeks onwards if she had been a monochorionic pregnancy?
Ma'am, biometry we will do.
Yeah.
To selective FGR, and also we will look for amniotic fluid index, the deepest vertical pocket, and we have to rule
PSV of middle cerebral artery. From 20 weeks onwards, we will see PSV.
Okay, so your aim at 16 weeks ultrasound to see whether there is, suppose she's a monochorionic pregnancy, there is development of twin to twin transfusion syndrome. Okay, so what are the parameters which you see on ultrasound in a case of TTTS?
I mean, in case of TTTS, initially she will be monochorionic twin, so there'll be single placental mass, and we will look for there are deep vascular anastomosis in cases of monochorionic twins. So there'll be estimated fetal weight discordance. There can be estimated fetal weight discordance, and there can be
donor twin will be having anemia. Donor twin will be having anemia or oligohydramnias. Then
ma'am, there is Quintero staging. We will stage her according to that. We will look for the if one twin is having oligohydramnios or other twin is having polyhydramnios, and bladder of the bladder will check for both the twins, and whether she is having any hydrops. If
urinary bladder.
Yes, ma'am, urinary bladder.
What you will see?
Ma'am, in case of donor twin, if the urinary whether the urinary bladder is visible or not.
Okay. Then,
ma'am, if it is visible and we are seeing oligohydramnios in twin A and polyhydramnios in twin B, and bladder of twin whose donor is visible, then it is stage 1 according to Quintero staging. And if the bladder is not visible, then it will be considered stage 2 twin transfusion syndrome.
And stage 3?
Ma'am, in stage 3, there'll be abnormal
Doppler changes.
Okay. So you said in your history that twin A, she faced less fetal movements in twin A. How you could support this finding?
Ma'am, patient came to us with complaints, so we wrote it in patient's language, ma'am.
No, patient's language, but how do you interpret it now?
See, you
Ma'am,
should
it's hypothetical that it's twin A. Actually, it could be any twin.
Yes.
Exactly what we are trying to tell you. Even if patient tells you something, when it is your exam, please present a logical history. You just can't say everything what the patient tells you. And even if you tell us that she had decreased fetal movements, it would have sufficed. Now, going back to your case, which is a DCDA IVF conceived. So now you have started focusing only on DCDA twin. She's also an IVF pregnancy. So do you have any additional advice for her from the first trimester onwards? And you have not told us what was the reason for her IVF.
Ma'am, her AMH was low, her follicular reserve, ovarian reserve was low. AMH was around 0.6. So that is why, and she had ovulation induction prior 3 to 4 cycles, which were failed. And post that, because as her reserve was low, AMH was low. So instead of IUI, she was taken to IVF.
So quite expected. She's 39 years. And that is, so any additional advice you will give to this patient, which is usually the norm in IVF pregnancies?
Ma'am, we will advise her that she is also she's more likely to develop more complications as compared to other twin pregnancies, such as preeclampsia, according to Gestosis score.
What is the role of aspirin in?
Yes, ma'am, we will start her on aspirin.
For prevention of preeclampsia.
Ma'am, aspirin, according to the aspirin trial, it reduces the risk of having preeclampsia by 60%.
Preterm preeclampsia, term preeclampsia?
Preterm preeclampsia.
In twins?
Yes, ma'am.
I'm asking in multiple pregnancy. All right. Let's go ahead with your...
I just want to ask if aspirin trial did include twins.
Yes, absolutely.
Aspirin trial was for singleton. Okay. Yes. So twins, it is not applicable.
But there are no guidelines, set guidelines for the twins, but there is literature coming up. Okay, we'll come back to this later. So go ahead. So now, how will you go ahead with her care? So you have done one scan in the first trimester, the conventional first trimester screening scan.
Yes, ma'am.
When is the next scan done for a dichorionic diamniotic pregnancy?
And also, preterm labor to predict, will you do cervical screening? Is that important?
Yes, ma'am. Yes, ma'am.
Role of progesterone.
Yes, ma'am. If the cervical, ma'am, during
that was one thing I wanted to comment on when I was asking you additional care during the first trimester for a IVF pregnancy. So will you give her progesterone for luteal support during the first trimester because she's an IVF pregnancy?
Yes, ma'am.
Yes, ma'am.
Okay.
Ma'am, during anomaly scan, we will look for the cervical length. If it is less than 20 mm, then micronized vaginal progesterone can be given to patient.
Okay, what is the care you will give to a twin pregnancy? What is the frequency of visits? What all will you examine in the in her antenatal visits?
Ma'am, for DCDA twins, she should visit 4 weekly. And if it is monochorionic twin, then every...
Monochorionic, please stick to your patient.
Okay, ma'am. Ma'am, every 4 weeks, we will ask her to come for the ANC visit till 28 weeks. And after that, every 2 weeks.
What all will you examine in every visit for a pregnancy like this?
Ma'am, we will examine her general conditions, ma'am. And also we will look for her BP. And we will...
For abdominal examination.
Should you not
And-
start with
and
history?
weight gain.
Should we not start with the history of the patient?
Yes, ma'am.
What all will you inquire from her?
Ma'am, we will inquire from her about her symptoms, if she's having any pedal edema or any symptoms of
excessive vomiting.
In first trimester, we'll ask
First
for
trimester wise, we will ask the history. In first trimester, we will ask whether she's having excessive vomiting or history of any bleeding PV, bleeding per vaginum, discharge per vaginum.
So now we are in the second trimester, no?
Yes, ma'am.
having any PV or pain in abdomen because we want to rule out if she's having any preterm labor signs, and also we will look for pedal edema and also ask about the signs of
increased frequency of micturition. Also, we can ask.
And these patients are also more likely to develop IHCP, or so we will ask for itching, if whether she's having any itching.
Isn't it a little too early for itching? Second trimester is
Ma'am,
usually not the time for
late second trimester.
End of the second trimester.
You have done a second. She has come to you in the second trimester. You have taken a history. You have done an examination. Anything in your mind which you will keep when you are doing her ultrasound, the anomaly scan. Besides looking for anomalies, what is important in the ultrasound examination of twin pregnancy?
Ma'am, cervical length during anomaly scan.
That we have talked about. Anything besides that?
Ma'am, fetal biometry.
Yes, and what else? She's a twin.
Doppler, ma'am.
No, not Doppler. In the biometry, what else will you look for? Right from.
Ma'am,
estimated fetal weight.
Estimated. Ma'am,
Yes.
AC, HC, and estimated fetal weight.
Fetal weight.
Do
rule out discordancy.
Check for discordancy at
Yes,
every scan in a twin pregnancy. All
Okay.
right. So now how do you follow up this patient? 20 weeks, then next visit?
Ma'am, 24 weeks. We will ask her to bring 75-gram glucose test also during that visit.
This is the first time you will ask her to do her OGTT?
No, ma'am, at first visit also we had done.
She has many high risk factors. She's
Yes,
9 years old woman. She's an IVF pregnancy. She's a twin pregnancy. So, all right. And at 24 weeks, anything else you'll ask for?
Ma'am, other than the preeclampsia testing, will
again you'll keep on doing scans at every 4 weekly interval.
Yes,
what is the objective of doing these ultrasounds every 4 weekly?
Ma'am, to rule out the discordancy, growth discordancy.
Anything else? Anything else?
And ma'am, whether she's having TAP syndrome, which can also occur with no, that will be in monochorionic, ma'am.
Even in dichorionic, there can be
fetal growth restriction.
First objective is to monitor fetal growth. Why come at discordancy?
Yes, ma'am.
You want to see whether both the fetuses are growing well and whether there is any discordancy or there is any selective growth restriction or both fetuses have growth restriction. All right.
Yes, ma'am.
Or there is a fetal demise.
Yes, ma'am.
There can be a fetal demise also in a DCDA.
Yes, ma'am.
So then, suppose this is a DCDA twin and there is demise of one fetus.
Yes, ma'am.
At 24 weeks of pregnancy, how you will manage this pregnancy?
Ma'am, in second trimester, there will be release of thromboplastin. If there is death of one twin, then there will be release of thromboplastin, which can cause coagulation disorders or any renal damage or cerebral palsy. But in case of in comparison to monochorionic twins, these risks are comparatively lesser in dichorionic twins.
It is lesser, agreed. But suppose if it happens, then what you will do?
Ma'am, we will monitor patient by every 2 weekly. And
we can give rescue transfusion also.
Huh?
We can give rescue transfusion also.
She's not that cause of demise is not. She's not a monochorionic twin, but there is demise, and the second twin is okay. Second twin is doing well.
And by coagulation profile, we'll monitor her, and by ultrasound, by the two methods.
Okay.
So understand that this coagulation is just a theoretical risk. It really does not happen. And you have to treat it now like a singleton pregnancy, and you will follow up like a singleton. The growth
Expecting management will give in case of deciduate twins.
Yes. So what I really wanted that you will be doing, and suppose the same thing happens at later pregnancy, still later pregnancy, may it be 34 weeks of pregnancy, then
ma'am, also the steroid giver will be given, and we'll monitor the patient, ma'am, as far as she's fine.
Counseling of the patient again. At every step, you have to counsel the patient about the pros and cons of both the things, that what is going, and if we deliver at 34 weeks because of that. So you have to counsel the patient and treat her accordingly.
Okay.
Yes. Anyways, suppose she reaches now. You have said that this patient is in labor.
No, ma'am. She came with complaint of decreased fetal movement.
Okay, so how you will monitor this patient at this period of gestation?
Ma'am, by doing ultrasound, we did her ultrasound. We'll look for
physical score and continuous CTG monitoring.
Then?
And ma'am, we'll ask her to get the ultrasound weekly, and we can deliver her by 37 to 37 plus 6 weeks of gestation. If everything is...
The presentation of first twin is, she's as such IVF conception with a donor egg.
Yes, ma'am.
So what decision you are going to take in this patient?
Ma'am, after counseling the patient, we can ask her to that 36 weeks, she has reached 36 weeks, and we can ask her, we can induce the labor if according to the presentation, ma'am. In this patient,
but she is an IVF pregnancy with donor egg. So what counseling will you do with the patient?
Ma'am, she's precious pregnancy. She's advanced maternity with donor egg. So we will counsel accordingly. So we'll ask the patient that we can deliver her now at 36 weeks of gestation. And mode of delivery can be decided, ma'am, according to the presentation.
Comments of my fellow colleagues?
See, one thing I want to tell you is, you have just said that she has decreased fetal movement and you have done an ultrasound for Manning's and NST. I think that is not sufficient. Very important is to do a biometry and Doppler and pick up whether this is FGR or non-FGR. All right. One is this. So if it is an FGR at 36 with an IVF donor, I don't have any reason to take her more than this. She's already 36 weeks, as good as a singleton term. I think I try to terminate the pregnancy. Next thing, which I think Dr. Sangeeta is asserting again and again, with such a high risk pregnancy, will you rethink your mode of delivery?
Ma'am, we will ask for the cesarean. We will counsel the patient about the cesarean section, as she is precious pregnancy.
Now, my next question is, what special points you will counsel the patient of a twin pregnancy when you are taking her up for cesarean section? You have to counsel and take the proper consent in a case of twin pregnancy being taken up for cesarean. What else you will tell, and how you will first the consent and counseling, and then how you will prepare her for cesarean?
Ma'am, she is more likely to have PPH. So we will counsel her about the PPH and that she might require blood transfusion, and it could be multiple blood transfusions. And ma'am, about the PPH also, and
yes, carry on. Okay, now how you will go ahead for cesarean? How you will prepare this patient, yourself, your OT, or everything for this patient with twin pregnancy cesarean?
Ma'am, there should be an obstetrician. There should be 2 pediatricians available, and and senior anesthesiologist, and two large bore IV cannula
IV cannula.
And blood products should also be arranged. And two pediatricians should be there, ma'am.
Okay. And suppose this patient, this pregnancy was not an IVF pregnancy,
Yes,
then
ma'am.
how you will go in with this pregnancy, this labor?
Ma'am, then if this was not a precious pregnancy, then we could counsel about a patient about the induction of labor. And
followed by mode of delivery according to the presentation
ma'am.
of the first.
Induction of labor is planned at 36 weeks. In all cases of BCDA twins, primary 36 weeks.
No, ma'am.
No, ma'am, not at
37 plus 6.
So we are at 36 weeks. So
yes, ma'am.
And we will monitor her frequently. We'll admit the patient and we'll monitor her by doing NSTs and by ultrasound, ma'am.
Okay, then keep on telling whatever you want to say. Keep on saying. Don't wait for my next question. You tell delivery.
Ma'am, we'll monitor the patient, and as soon as she reaches 37 weeks, we'll start the process of induction of labor. And if the first twin is vertex, and then a decision is taken according to the presentation of first twin. If the first twin is vertex, then she can be delivered vaginally.
Normal vaginal delivery.
Our patient was first twin, both the twins were vertex. So, but this was ideal conception.
What is the complication expected in a case of both the twins vertex?
Ma'am, there could be both the twins could not enter the brim. If there could be
delayed engagement can happen.
Yes, ma'am. There could be problem in engagement of the head in the pelvic brim if both the that could.
So you tell me, are you thinking that both the vertex are delivering? You tell me the delivery of both the twins step by step.
Ma'am, after the delivery of the first twin,
can I ask something before?
Yes, please.
Before for delivery, what preparation do you make when you're planning to, when you know that your twin pregnancy has gone into labor? What preparation will you make as soon as your patient comes to the labor room?
Ma'am, there should be senior consultant, senior obstetrician available. We have to inform the anesthetist also that this patient can be taken for cesarean if any complication occurs in between, and we have to inform the pediatrician. There should be two pediatricians available, and two IV lines secured. And
adequate blood and blood products for
very
the
good.
patient.
Yes, adequate blood to be arranged.
Yes, ma'am.
Cannula to be put in place.
Yes, ma'am. And we will also advise the patient to not have any anything orally, because she can be taken for surgery. Adequate hydration is important, but soft or normal diet is not
liquid.
Yes, she can be on liquid. Yes. And she should be explained that the incidence of operative intervention is going to be higher. And
yes,
how will you monitor the first stage of labor in this lady?
Ma'am, during the first stage of labor, ma'am, we will not ask her to walk. We will ask her to, we have to prevent the premature rupture of membranes. So, and continuous CTG monitoring should be done.
I don't think that is the limitation in the lady, but you have to be careful that there is a likelihood of prolonged labor and incoordinate uterine action, which is more. So you should monitor her for that, and you have to keep a strict watch on her fetal heart rate. So you may need 2 CTGs simultaneously to monitor them. All right. Okay. Now you can answer the question for the second stage of labor.
Ma'am, after the delivery of the first twin, oxytocin is not given, and we have to see the line presentation of the second twin. If it in this case it was vertex, so as soon as the head engages, we have to do low rupture of the membrane. And
please. So you will only look for the lie and presentation of the second twin after you deliver the first baby.
And fetal heart also will look for the fetal heart. Continuous fetal heart monitoring should be done during.
What else? What else will you look for? So what is the intensity duration of contractions after the delivery? Also, if the uterus is not contracting adequately,
yes, ma'am, we'll look for the
have to augment the labor with syntocin.
By oxytocin. Yes, ma'am.
Can you use some aid in the labor room? Which is very commonly used by all of us nowadays in obstetrics. It is become almost the eyes and hands of obstetrics. So if you have an ultrasound machine.
Confirm the presentation of the coming twin. Can you?
And what else will you look for? What else will you do? Okay, so now it is a cephalic presentation. The fetal heart is good. What else?
Ma'am, whether the head is engaged or not. If the presenting part is engaged, and then we can do we can do a rupture of membranes. And if there is delayed in delay in the delivery, then we can also intervene with the operative, like forceps and vacuum. We can also apply the forceps and vacuum if there is delay.
What do you mean by delay?
More than 30 minutes.
Ma'am, 30 to 45 minutes. After 30 to 40.
You can also start a synto drip because the uterine action may be less or
incoordinate.
Okay, then.
Ma'am, after the delivery of the second twin, active management of the third stage labor will be, as they are more likely to have PPH. And ma'am, placental examination should also be done to look for the
Okay. Suppose now, what are the indications of cesarean in a case of twin DCDA twin pregnancy, leave aside IVF? What are the presentation which will require you to take the patient for elective cesarean?
Ma'am, the first baby is in breech presentation, then we can take up
non-vertex presentation. If the first twin in non-vertex position, then.
Now, suppose first, in this case, first vertex has been delivered and second is in a transverse lie. How you will manage this patient?
First, we will do the try to do the external podalic version. If that is possible, then we will go for it and try external podalic version or external cephalic version, whichever is nearest to the external. Also, then if that is possible, then well and good. Otherwise, we will go for internal podalic. We will shift the patient to OT, and then under general anesthesia, we will do the internal podalic version by putting the hands inside the uterus and try to bring the feet of the fetus to the lowermost part.
And doing a breech extraction. Okay. Yes, so after the delivery of the first baby, what are the indications for cesarean for second baby?
If the second baby is in transverse lie, if the delivery of the second baby takes more than 30 minutes, 30 to 40 minutes.
And in case of fetal distress,
if there is a cord prolapse?
In case of cord prolapse, and in case of
if there is no, not in this.
Any addition from your side, Dr. Sangeeta?
I think if the second twin is larger than the first one and you could not pick it up prenatally, and there is failure of descent of the presenting part, and the baby is fine, or the baby is having distress, and you don't see a vaginal delivery possible, safe vaginal, that's important. That is something which you should keep in mind, and that is one assessment which should be made soon after the delivery of the first twin. And ideally, one should have done a biometry scan beforehand once you're leaving a twin pregnancy for vaginal delivery, that the second there is not significantly larger than the first twin.
Yes, ma'am.
I think Aparna and Reema have hardly asked anything. Aparna?
Dr. Aparna has reached home. Now she will be taking the...
So, very good evening to all. So, essentially, I just want to, can I go back a little bit? I have a few points from the history and examination.
Yes.
Yeah, so essentially, first of all, like Dr. Sangeeta said, it's very, very important. So the donor part was missing. That is extremely not acceptable in an IVF pregnancy, which is either singleton or twin, right? Now, when you come to a twin pregnancy, the first thing is, how have you dated that twin pregnancy?
Ma'am,
Right?
according to if we are taking the embryo transfer date, then from that will minus 14, and this was day 5 embryo transfer. So
Total
You have
minus
taken
19.
dating from the ET.
yes,
Okay?
ma'am.
As I understand, you have dated from the ET, so that's very important. But why not from the LMP? And which is preferred? Is there a preference? Yes or no? Just a yes or no.
Yes, ma'am.
What is
And
yes?
this was donor
Preference.
Donor or doesn't matter. Donor or self-egg doesn't matter. It just matters whether it is ET dating or LMP dating. So basically, it's a controversy. It's not really clear whether it is LMP dating or ET dating, but ET dating is definitely preferred. Now, the next thing is, okay, you are doing an ET dating, but there are 2 babies, right? So which babies you will use to date? Which baby you'll use to date?
Ma'am, the baby having larger CRL on
And why will
ultrasound.
you do that?
Ma'am, because the smaller one can be smaller because of the anomaly or
Or later on, what do you want to detect?
growth restriction. Ma'am, growth restriction.
Fetal growth restriction.
What is the percentage when you call that it is growth restriction? What is the discordance when you define that it is?
More than 20%.
Is it 20%? What is the Delphi criteria?
Ma'am, if the estimated fetal weight is less than 3rd centile, or if the AC or estimated fetal weight less than 10th centile and abnormal Doppler,
Doesn't apply in twins. So go back and read Delphi. So
Okay.
one is estimated fetal weight less than 3rd centile. The other things apply, but the discordance which should be more than
25%.
20 to 25%.
5%, right? And when you add monochorionic, you have to add the AC also. Now, the next thing that you also told about in history, which is really
Aparna?
not acceptable. Yes,
Aparna,
ma'am.
just tell them one more thing. See, when you do a scan in a twin pregnancy, even in the first trimester, you should record the discordancy between the CRLs also.
Just coming to that point. Yes, ma'am.
Carry on, please.
Exactly. So the first thing is when you do a first trimester scan, what is your CRL discordance? So what level of discordance is important? And why is it important?
Ma'am, it should not be more than 12 mm.
Yeah? No. In terms of percentage.
Because it will keep on varying. 12 mm cannot be at 11 and 13 plus 6 weeks. No, it can't be same.
Yes. So in twin pregnancy, CRL discordance in the first trimester is extremely important, whether it is 10% or 15%, 10% for monochorionic, 15% for dichorionic. It is extremely important predictor of future stillbirths and complications. Now, the next question is, why have we done a dual marker in twin pregnancy? What is the, so are you happy with it? Is it an ideal screening protocol? What is an ideal screening protocol?
Ma'am, in case of the ma'am, this patient was Ma'am, dual marker, we have to check for the biomarkers.
But it is correct. So an FTS,
because of the age of the patient, there are more chances of.
Ma'am, this was donor, so we'll take the age of
the donor, right? So for a normal twin pregnancy, you can offer FTS. But if it was a self-egg, then you would not offer an FTS, you would offer an NIPT because the risk of positivity is high. Another thing that I want to say is you said that the patient presented with decreased fetal movement, right? You did a Manning and then you said sluggish movements. There's nothing like that. You cannot present like that. Manning is 8/8, then you say 8/8. If you find a lesser tone, then you say 6/8, right? So you have to be very careful on when you're wording your history. You cannot be vague about it. So there is nothing like a sluggish movement. If you are subjective about it, you need to think about it. Why you're subjective, repeat, unless you're happy with it or you deliver.
Yes.
Right?
And one more thing which I wanted to say was that it is very important to look for NT also, NT discordancy also. Particularly if it is a monochorionic, because that's an early marker of
twin transmission.
Yes, twin transmission syndrome.
Yes, absolutely. And NT discordance, it will go on increasing. And there are studies which have shown that up to 18% discordance is still okay. But yeah, the amount which increases, it is fine. The other thing that I want to ask about is you very, casually talked about the diet. So diet in twins cannot be so, single statement. So how do you actually calculate diet in twins?
Ma'am, additional 300 kilocalories will add.
What additional? So what is the baseline?
40% carbohydrates and high protein intake.
The total calories.
Calories.
What is the total calories in your patient? So when you present a history of a dietary history, you take a pre-pregnancy BMI, then you take the current weight, then you take the amount of calories which is required. So if the pre-pregnancy BMI is normal, you multiply that by your current weight.
Okay.
Right? And then 30 kilocalories per kg. But if it's a twin pregnancy, it becomes 40 kilocalorie per kg. Right? So your diet
lifestyle.
Yes,
and
and
the lifestyle.
The amount of physical activity. So I would suggest that being an exam going person, postgraduate, when you present a dietary history in twins, it has to be more meticulous. Also, what is the calcium intake? Is it singleton wise or a twin wise? How much do you give to a singleton?
1000 mg per day.
How much do you give to a twin?
1000 mg per day.
1500. So calcium intake is more. What about the iron intake?
100 mg per day elemental iron.
100 mg. Singleton? We
Ma'am,
are
600
100 mg is long back. Singleton कितना देते हो?
Ma'am, 60 mg.
Twin में क्यों 100? So it's basically twice the dose. So twin is increased. Then the other thing is, why did you do a PV? In this patient who has come to you with decreased fetal
Before
movement.
that, Aparna, can I tell them something more?
Yes, ma'am.
See, one thing in your history which was grossly missing was, so you must ask the patient actually what she has gone through. You just told us one scan at 11 weeks, another one at 20 weeks. And then you are telling you have to monitor the patient every 4 weekly with scans. All right. And I think an IVF pregnancy like this must have had scans much more frequently than maybe 4 weeks. Anyway, second very important thing in the examination was you just declared this is the symphysiofundal height. No correlation, whether it is more than your period of gestation or amenorrhea here more than period. That one line of symphysiofundal height is this much centimeters is corresponding to more than or less than period of amenorrhea is very important, because that will become, and girth also, that will become one of the reasons if we would have asked how on clinical examination did you make a diagnosis of twin pregnancy.
Yes,
all right. So these are some, don't get so carried away with your, because you know the diagnosis and you know the patient, don't get carried away. Just treat a patient like you have seen like any first time, any patient you see, you examine and you talk.
Okay.
And one more thing, in your diagnosis, you did not mention the age of the patient, which is a high risk factor for this woman. In IVF pregnancy, in bracket, please write donor. And I don't remember what was her BMI like. What was her BMI?
22, ma'am.
Huh? 22.
Ma'am, according to pre-pregnancy weight, her BMI was 22.
She was 75 kg, by 65 kg. She was 14 kg.
Right.
What was her height?
158 centimeters.
Sorry?
158 centimeters, ma'am.
She's tall. She's tall.
So, ma'am, just 2 points before I think Dr. Reema can ask a few more questions. But I would just like to say that why did you do a PV at 36 weeks when a patient is not in labor? So I think whenever you're presenting in exam, just weigh your words very carefully on whether a PV is needed at this stage. If you've done your Mannings, the patient is not an indicated delivery at the present time. Why do you need to do a PV? Presentation you have anyways understood by the ultrasound. So it's important that you mention this word PV very, very carefully. Do not do unnecessary PVs. The other thing is you said that for prediction of preterm labor, a cervical length assessment would be done at what gestation?
Ma'am, 16, we have to start it by 16 weeks, ma'am.
Okay, it is not started. Generally, a single cervical assessment is done in twin pregnancy. And if the length is less than 25, you will add a progesterone. So micronized vaginal progesterone. Yeah. So I think there are a lot of other points, but I think let Dr. Reema, I think we have 6 minutes left. So Dr. Reema, you can take on what we have missed.
Okay, I think it's complete as far as the case is concerned. We could just take up some scenarios. Now, if you have a twin pregnancy, dichorionic with an anomaly, what would you do? And it's an omphalocele or it's an encephaly. How would you approach this patient?
We will do a selective fetal reduction.
For
if
all?
it is diagnosed in the early first trimester.
It was also
It will depend on the kind of anomaly. So if it's something that leads to polyhydramnios or it's a problem, then probably yes. Otherwise, if you do a reduction, you would increase the risk of aborting the entire pregnancy. So you'll have to really call it that. Okay, so if it's a monochorionic twin pregnancy and not a dichorionic twin pregnancy, what are the complications you're anticipating? And is there a way, do we need to treat or do we need to just leave it alone? What are the complications?
In monochorionic pregnancy, we see twin-to-twin transmission syndrome. Then we see twin anemia polyhydramnios. Then twin arterial perfusion syndrome.
And why is it
twin reverse arterial perfusion?
Why are we worried about Yeah, so why are we worried about TTTS, SFGR? Why are we so worried in them? Why do we need to so aggressively follow them?
Ma'am, because these can lead to these can increase the mortality of the fetus, and they can ultimately lead to IUD if we do not monitor and do not treat.
So one fetus dies, it's okay. The other fetus is alive. Why do we need to? Why are we so worried? In DCDA, we don't worry so much. But why
monochorionic? But in case of MCDA twins, there are more chances of a survivor twin to get affected by the death of the
neurological damage.
Neurological.
Yes, ma'am.
Yes. When you treat it, so if it's TTTS, would you want to do, what are the modalities of treating TTTS?
Ma'am, before amnio reduction, we can do, ma'am, radio frequency ablation. And
if there is oligo and polyhydramnios, we can do amnio reduction also.
No, if it's TTTS, we are not talking of SFCR. If it's TTTS, what would be your first line of, what would be the best method of treating?
Ma'am, radio frequency ablation.
Radio frequency ablation of vascular anastomosis.
RFA of, no, that's laser of the vascular anastomosis.
Yes,
so you will, so depending on the Quintero staging, laser is the best treatment. Because by you don't do RFA of the placental anastomosis, it's laser therapy for the anastomosis. And if it's SFGR, if the one baby is small, the other is big, and if there's chances of problem, then and the Dopplers are deranged, then what can you treat? How can you treat them?
Ma'am, if the selective FGR is of grade 1, then we can monitor the patient frequently. Every weekly now we have to monitor the patient. And if the situation is not deteriorating, then we can deliver her by 36 weeks. But in case of if the stage, according to the stage 2 and stage 3 of selective FGR, then we have to give the steroids to the patient, and we have to plan delivery by 32 to 34 weeks.
And is there any role of selective reduction of one of the twins? So there is role of RFA, what radio frequency ablation that you spoke about. We can reduce one of the twins. Or we
in
can
case of early onset FGR, ma'am, we can do.
Yes, early onset FGR, we can do interstitial less than 26 weeks. Doppler abnormalities, we have the option of RFA, we have the option of bipolar coagulation, we have the option of laser, etc. available. So these are treatment modalities that are available. I think you need to know a little of these monochorionic complications because that can be asked in your exams.
Okay, ma'am.
And one last thing which I wanted to say was that even if you have to do a PV examination, the objectives of a PV examination is to do a Bishop score. So when you say your PV, please don't say small. There's nothing like small or I think, can you just show me that slide? So make sure you have covered all the points of your Bishop score. And for a woman who's a primary pelvic assessment is an important part of your PV examination, and to comment on any cephalopelvic disproportion. All right. So you should make sure your points are as per, and then tell the Bishop score, tell about the pelvic assessment, and talk about cephalopelvic disproportion also. All right. So, Aparna?
Yes, ma'am. So I think we have covered most of the points.
No, I want you to comment on preeclampsia screening and aspirin for multiple pregnancy. That they should go clear with. I think that was not clarified.
Yeah. So essentially, the concept of preeclampsia screening in multiple pregnancies is a little different from singleton. The studies have shown that if you apply the same parameters that you apply for singleton pregnancy, then 75% of your twin pregnancies will come positive because they're baseline high risk. So essentially, if you look at the ACOG criteria and also the NICE guidelines recognizes twin pregnancy as one major factor for starting as.
I think we have lost you, Aparna. So what she wanted to tell and what most of the
Started
guidelines.
in most of the NICE guidelines that aspirin should be started for twin pregnancies. We can go ahead because if we start doing the preeclampsia start aspirin in all cases. In this particular case, aspirin was started. I don't know if it was started for an IVF pregnancy or a twin pregnancy.
Are we losing Aparna in between, or is it my
Connectivity is poor, ma'am.
No, no, ma'am.
So
we lose.
So I think.
So, am I audible?
Yeah, Reema, you carry on.
Yeah, I'm just saying that important point to mention here is that twin pregnancy is a major risk factor for preeclampsia according to history-based screening. And the NICE guidelines and majority of the guidelines do recommend starting aspirin for a twin pregnancy. The reason being that if we screen with all the multimodal parameters, more than 70% of the pregnancy. So twin pregnancy is an indication to start aspirin, and we should be starting aspirin. So this pregnancy was started on aspirin. So that's the good part.
And I think these are the points you should bring forth in your history. That patient was started on aspirin, whether she was on progesterone support right from the beginning of the pregnancy. So these things you should bring forth in your history. Patients are quite intelligent nowadays, and if you ask them, they will let you know most of the things.
Yes, ma'am. Thank you, ma'am. I think we have just crossed the time. So I would like to thank all the moderators for the session. Dr. Sangeeta ma'am, Dr. Reema ma'am, Dr. Aparna ma'am, and Dr. Sangeeta Gupta ma'am. Thank you so much, ma'am. It was an interactive and a very good session by all of you. Thank you, presenters, Dr. Payal and Dr. Maria.
Thank you, ma'am.
Thank you, ma'am.
So
Nice
next
presents
one moment.
Payal and Maria.
Yeah, the girls have really done quite well, and all the best for your exams.
Thank
And
you so much, ma'am.
just take one moment. We have a postgraduate, the famous postgraduate course of MAMC on 9th, 10th, and 11th of August.
Yes, ma'am.
Just all the postgraduate students to please join us for that. Thank you so much.
Thank you,
And
ma'am.
thanks to Gangaram team to call us here.
Yeah, thank you, Gangaram team, and all the best to both of you.
Thank you, Gangaram team, and all the best to Payal.
Thank you, ma'am. Bye, ma'am. Thank you, ma'am. So moving on to the next session, we have a case presentation on postmenopausal bleeding. So for that, I would like to call upon the moderators for the session. Our first moderator is Dr. Harsha Kullar ma'am. Ma'am is a senior consultant in Department of Obs and Gynae at Gangaram Hospital, and she has been the president of the Delhi Gynaecology Forum Central part on from 2022 to 2024. The next moderator for the session is Dr. Sumita Mehta ma'am. So as we all know, ma'am is in charge and senior specialist in BJRM Hospital in New Delhi. And the third moderator is Dr. Archana Dwivedi. Ma'am is a very famous gynecologist in Vadodara, and she is the national chairperson of the IMS website committee 23 to 2025. So welcome, ma'ams. And I would like to call upon the presenters for the session, Dr. Rutushree Pattnaik and Dr. Maria Haroon. Both are DNB resident, Prince and Gangaram Hospital. So Rutushree and Maria, are you ready with the case?
Yes, ma'am.
Yes, ma'am.
Okay. You can share your slide here now.
Is the slide visible, ma'am?
No, not yet. Not yet.
Ma'am, is it visible now?
No,
Not
no, no.
yet.
It is
Rutushree, it hasn't started. You sharing the screen?
Yes, ma'am, I'm sharing, but I don't know. Is it visible now, ma'am?
Yeah.
Yes, now we can see.
You can go ahead with the presentation.
So we'll be presenting a case on postmenopausal bleeding.
Start your please.
Mrs. X, wife of Mr. Y, 64 years old, postmenopausal lady, resident of Punjabi Bagh, Delhi, belonging to upper middle class according to modified Kuppuswamy scale. Her chief complaints were she presented with postmenopausal bleeding per vaginum on and off since 1 year, which has increased since 1 month. History of present illness. The patient was apparently asymptomatic since 1 year when she started complaining of bleeding PV on and off, which has increased since last 1 month. Previously, she had history of spotting per vaginum 3 to 4 episodes since last 1 year, each lasting for 1 day, for which she noticed only on wiping with tissue paper or staining undergarments. Since last 1 month, she had to use cotton pads for bleeding, which were half soaked and needed to change pads twice daily, and which was fresh red in color. It was spontaneous in onset and spontaneous in resolution. Bleeding PV was also associated with mild pain in lower abdomen. She had no follow-ups previously since the last 16 years. There was no history of any associated foul-smelling vaginal discharge, hormonal drug intake, topical application, vaginal pessary use, or any anticoagulant intake. There was no history of any genital trauma, ulcer in private parts, or pelvic surgery. No history of urinary complaints, bleeding per rectum, pain during defecation. There was no history of distension, fever, weight loss, loss of appetite, nausea, vomiting, constipation, and easy fatigability. No history of cuff and hemoptysis or breast lump in breast. No history of postcoital bleeding or mass per vaginum. Her menstrual history. She attained menarche at 13 years of age and attained menopause at 48 years. She is postmenopausal since 16 years. She had regular period cycles previously. Her obstetric history. She has been married since 40 years. There was no history of infertility. She is para 2, living 2, both cesarean deliveries. Her last childbirth was 44 years back and she used barrier method of contraception. Past history, she is known case of type 2 diabetes mellitus, hypertension, and hypothyroidism. There was no history of any cancer. Family history, no history of any chronic medical illness. She had history of uterine cancer in grandmother. There was no history of colorectal, ovarian, or breast cancer in family. Personal history, she is educated till graduation, vegetarian, bowel and bladder habits were normal, no history of any addiction or allergies, and she belonged to upper middle socioeconomic class as per modified Kuppuswamy scale.
Examination. General physical examination. Patient was conscious, oriented, cooperative. She is morbidly obese. General condition fair. Hydration status adequate. No pallor, icterus, clubbing, cyanosis, and lymphadenopathy. And edema. Afebrile to touch. BMI was 42 kg per meter square. BP 130 by 80 millimeter of mercury in right arm in sitting position, pulse rate 80 per minute, regular, no radio delay, no radiofemoral delay, respiratory rate 160 per minute, thoracoabdominal, thyroid normal, no enlargement seen, bilateral breast normal, no lump felt, no discharge from the nipples. Systemic examination. CVS S1 S2 heard, no murmurs, respiratory rate, bilateral air entry equal, no added sound, CNS, no focal neurological deficit. For abdominal examination on inspection, patient was obese, midline vertical scar present, umbilicus central and inverted, no dilated veins or visible pulsation seen. On palpation, soft, no hepatosplenomegaly or mass felt, no guarding tenderness, rigidity. On percussion, resonant note felt, heard all over the abdomen. On auscultation, normal bowel sounds heard. External genitalia examination, vulva atrophic, urethral meatus normal, anal opening normal. Per speculum examination, narrow introitus, vagina atrophic, cervix was seen with difficulty, flush with vagina, pinpoint os, no discharge, bleeding, ulcer or growth seen in the cervix. Per vaginal examination, uterus size and mobility could not be assessed due to obesity. Bilateral fornicis free. No thickening or induration felt in parametrium. PVR, rectal mucosa free. Bilateral parametrium free. No nodularity in pouch of Douglas. Provisional diagnosis, para 2, live 2, postmenopausal morbidly obese lady with previous 2 cesarean deliveries with postmenopausal bleeding with known case of type 2 diabetes mellitus, hypertension and hypothyroidism. Differential diagnosis. Endometrial hyperplasia with or without atypia, endometrial cancer, senile endometritis, endometrial polyp.
So from the history and examination, what do you think that can you pinpoint your diagnosis from the history and examination?
Ma'am, since she has history of diabetes, mellitus, hypertension, and hypothyroidism, she is morbidly obese, all of which are high risk factors for
Endometriosis.
endometrium. So my diagnosis most likely goes towards endometrial carcinoma.
What do you think are the high risk factors in this patient going in favor of endometrial cancer?
First of all, she is morbidly obese. Her BMI is 42 kgs per meter square. And she is also...
I have a question here. Why are obese women more prone to endometrial cancers or hypertension?
Ma'am, because in obese women, there is peripheral conversion of androstenedione to estrone in the peripheral conversion. That is why they have more chances of developing endometrial carcinoma.
Because of more exposure of estrogen, there will be more chances of...
From where is these androgens coming? The ovaries are not functional, isn't it, in menopause?
Ma'am, from the adrenals.
Adrenals as well as the ovaries. What happens in
As
menopause?
ovaries. Majority of
which cells are more affected? The granulosa cells or the theca cells?
The
granulosa cells.
Granulosa cells.
So the theca cells and the stroma are still forming the androgens.
Yes, ma'am.
Okay, so there is peripheral conversion for that, right? So one is obesity, you said. The other risk factor is?
Hypertension, diabetes, so that could be one of the reasons, because we know corpus cancer syndrome, in which obesity, diabetes and hypertension, all these cumulatively increase the risk for endometrial cancer.
Okay. What other factors? If we go back to the history, there are a couple of things that I, want to kind of add. Just go back to your medical, the medicines that you said. Yeah, if you go back. Medication history. So now this is OBS history. Now, when you come to OBS history, you have written, go back to OBS history. She's been married since 40 years, but her last child is 44 years. So this is wrong, right? You can't have a child before she gets married.
Sorry, ma'am. Yes, ma'am.
Another thing is that always mention... I know that's a typo error. It's fine. Another thing is that, always say that when did she have menarche? Does it have any bearing?
Yes, ma'am. Early menarche is also a risk factor for endometrial.
So that should be there.
So it's there in the menstrual history.
There in menstrual
history.
That's fine. Another thing, when you are talking about she's not on any hormone replacement therapy, not on anticoagulants, always ask about herbal supplements. Many times I've had patients who are taking herbal supplements for menopause. So they actually have estrogens. So always keep that also in mind. Though not very common, but it is there.
But phytoestrogens usually doesn't affect the endometrial sickness and all.
But They can cause, ma'am. They have been seen to be a risk factor and can cause. It is always better to ask this history. So now the risk factors you said were diabetes, hypertension, obesity. What else in this patient?
Hypothyroidism, ma'am.
Hypothyroidism also.
And then the socioeconomic statuses?
Ma'am, she belonged to upper middle class according to modified. So, lifestyle changes can also lead to endometrial CA.
Sedentary lifestyle.
So it's been seen that endometrial cancer is more common in the higher socioeconomic cervical cancer, which is more common in the low socioeconomic
status.
Yeah.
Rutushree, you said that history of varied methods for contraception. Why is it important to ask about the contraception history in a patient with PMB?
Ma'am, it is important because she might be using OCPs previously, which decreases the risk of endometrial CA, or she might have had intrauterine system for which she might have forgotten to take out, which increases the risk of endometrial CA.
Not the endometrial CA, maybe it is postmenopausal bleeding.
Foreign body inside.
Yes, ma'am, which might cause postmenopausal bleeding.
Why is asking about hormone therapy important? Hormone replacement therapy.
She might be having menopausal symptoms for which she might be taking hormone replacement therapy, especially when hormone replacement therapy is taken only with estrogen. Then it increases the risk of endometrial CA by 10 to 20 times.
So
without progesterone.
In situ, you have to give progestrogens also, right? So
yes, ma'am.
Now, once a woman is on HT, how do you define menopause in them? In normal patients, you say that if a patient hasn't had periods for 1 year, she's menopausal, right? After 40 years. What about women who are on HT? They can have irregular bleeding when you start right? So how do you label them as postmenopausal? Postmenopausal bleeding in them, in women who are on HT. Suppose I start HT on a woman today. She might have irregular bleeding. So will we call that as PMB?
No, ma'am.
Then when would we call it PMB in them? What are the two main methods of HT?
Ma'am, one is by oral route. We can give progesterone, estrogen.
Continuous and
cyclical.
Sequential, right? So
sequential,
now if a woman is on continuous HRT and she continues to bleed for 6 months. Once you have started her HT, but she's still having irregular bleeding for next 6 months, then you call this as PMB. And for a woman who's on sequential, if this continues for more than 3 months, then again you call it as PMB. So for the first month or second month, if they have irregular bleeding, you will not call it PMB in them. So there is a slight difference in definition of PMB in women who are on HRT and women who are not on HT. And then what is premature menopause? Now that we're talking about menopause.
Ma'am, attaining menopause.
For menopause.
Before 40 years of age.
So before 40 is premature menopause. And average age is how much?
From 45 to 55.
45.
What's the difference between premature menopause and premature ovarian failure?
Maybe I was going to ask this.
Okay, it is basically the same.
If it would be the same, we wouldn't be asking you this question.
So let's proceed further. So how are you going to, Sangeeta,
I'm going to tell them because they have to know the difference. Premature menopause care. If you have menopause, permanent cessation of ovarian function before 40 years of age. But POI is not permanent cessation. Basically, इसमें irregular anovulation होती रहती है बीच-बीच में. These women have also been seen to get pregnant at times. Yeah. So what are the main causes for POI? Generally, it is seen in which patients?
Ma'am, and Turner syndrome patients,
Mosaic
in
Turner hai, fragile X hai.
Mosaic Turner.
Yeah.
Yes, ma'am.
So they have irregular ovulation happening. So this is not permanent. That is the main difference between POI and anything else in history, ma'am? History seems to be all right, I think. Covered
So
almost.
why do you examine breast also in a case of postmenopausal patients? Although it should be examined in all the patients, but especially by postmenopausal patients.
Ma'am, because there are many germline inherited disorders which can occur in patients like HNPCC, hereditary non-polyposis colorectal cancer syndrome, which
cancer
has a
also.
combination of colorectal cancer, breast cancer, and uterine cancer.
What is
That
the
is why
percentage of the patients getting this type of this?
60 to 70%.
No?
No.
It's hardly 10
Percentage
to
of
15%, 10
Percentage.
to 15%. And in this patient, I think you said that her mother had uterine cancer or grandmother?
Ma'am, grandmother.
Grandmother. So that is very important to rule out that it is not that familial type of cancer.
Yes, ma'am.
So now coming to, I think history is done, Dr. Harsh, ma'am.
Yes, history is done. I think you have asked all the points which are. And secondly, I think you didn't mention about the history of contact bleeding, postcoital bleeding.
Ma'am,
I
it
didn't
is
see
there,
that.
ma'am. No history of postcoital bleeding.
Yeah.
Mass per vagina.
On examination, I think.
Causes have you ruled out? What are the causes for postmenopausal bleeding? History, so what
Yes.
have you tried to do?
Ma'am, there is no history of foul smelling discharge. One of the most common causes of postmenopausal bleeding is pyometra. That is why we took history of foul smelling vaginal discharge. And there is use of forgotten vaginal pessary or topical agents or forgotten IODs can also be a cause of postmenopausal bleeding. By hormonal drug intake, we specifically wanted to ask her about any treatment that
What
she
are
took
the
for.
main causes for, if I
Main
ask
cause,
for the causes
these are
for
the.
bleeding, so how would you list them?
Ma'am, senile endometritis, pyometra, endometrial hyperplasia, endometrial polyp, endometrial
Foreign
cancer,
body.
cervical cancer, any history of anticoagulant use. She
So,
might be having uterine
Tamoxifen.
prolapse with decubitus ulcer, which might.
if you divide it into uterine and extra uterine, will be easier. So uterine you will have all hyperplasias, cancers, polyps, and
Yes, ma'am.
Foreign bodies.
Foreign bodies.
Foreign bodies. So extra uterine would be anything in the cervix, vulva, vagina,
and ovaries.
Tumor, any foreign body, any atopic vaginitis would be all extra uterine. And there could be the other systemic causes. So what are the other systemic causes with which the woman can confuse it with vaginal bleeding? We have written no history of urinary complaint. Why?
Urethral
Because, ma'am,
carancule.
urethral
There
carancule or
can be urethral
urethritis sometimes.
carancule,
And there can be
which might
hematuria.
lead.
You never know.
She might be having hematuria. She might be having fissures for which she or history of hemorrhoids for which she is having bleeding
for
PR, but she might be confused that it is coming from vagina.
They are very important causes. So history of bleeding or pain during defecation to rule out fissures. So you've taken history, but if you have the causes in your mind as uterine, extra uterine, and other systems, then you never actually miss out anything that way. So your history.
Rutushree, this granulosa cell tumor of the ovary, that can also be one of the causes for PMD.
Yes, ma'am. That is why we took history of distension, fever, weight loss, if there is any to rule out ovarian cause.
Usually granular tumor doesn't cause any distension of abdomen and all, and they are not really very big also in size.
Okay.
What marker would you do for granulosa cell tumor?
Inhibin B.
And what if you have endometrial cancer and ovarian cancer? What stage would that be?
Ma'am, it comes under stage 3,
No.
stage 3
Listen to my
A2.
question. Listen to my question. What do you call? What if there is endometrial cancer and ovarian cancer, single side, unilateral, capsule intact, no LVSI?
Stage 1, ma'am, stage 1A, 1A3.
You're close to it.
1A3.
1A3. So there is a difference between whether it is ovarian mets or whether you have endometrial cancer with ovarian cancer. Then that.
Ovarian cancer.
So does this have a good prognosis or a bad prognosis?
And this has a good prognosis, but if it is associated with ovarian metastasis, it has a poor prognosis.
Good. That also you have to know. So then we come to the examination. History, I think, is more or less complete. We have covered almost everything. Personal, physical, you've said she's obese. Otherwise, there's no pallor. Pallor is important because if she's having PMB for quite some time, she might be pale.
Present with pallor, yes.
Now, lymphadenopathy, which lymph nodes have you seen for?
Ma'am, cervical, supraclavicular lymph nodes, cervical lymph nodes.
Supraclaviculars and cervical.
Ma'am, supraclavicular lymph nodes.
And what else should we be seeing?
Axillary lymph nodes.
Axillary.
Inguinal.
So three main that you really need to see are inguinal, axillary, and supraclavicular.
Yes, ma'am.
3 group of lymph nodes you need to see. Okay, this is fine, I think. Go on to the next slide. And examination, when you come to your PV examination, systemic is fine. This is all right. Per abdomen is fine. Go on to the next one. This is all right. Now here you're saying vagina atrophic.
Yes, ma'am. Ma'am, the vagina appeared pale. There were loss of rugosities there were loss of rugosities.
Why does atrophy occur in postmenopausal patients? Vaginal atrophy, cervical atrophy?
Ma'am, because of lack of estrogen.
Withdrawal of estrogen.
Withdrawal of estrogen.
Currently, when you say atrophic vagina, you mean that it is dry, there is loss of rugosities, and there might be pinpoint bleeding points, once you put in your
bleeding
because of the vessels being so superficial. So that
yes,
is, so you saw nothing, everything was fine except that that means the bleeding was coming from the uterus. That is why you've kept your first provisional diagnosis as hyperplasia or endometrial cancer, isn't it?
Endometrial cancer.
Now,
Yes,
how
ma'am.
do you confirm your diagnosis?
Ma'am, we can, ma'am, in this, we can do endometrial aspiration cytology.
Rutushree, excuse me, and then before, when you're examining a patient, can you do some test also? At the same time when you're examining the patient?
We will do the pap smear test.
So that is very important.
To rule out
Ma'am, we will do
cancer.
all the routine investigations for these tests like CBC, liver function test, kidney function test, blood sugar levels, thyroid profile. We will also do routine pap smear for cytology. We will also do an diagnostic testing like ultrasound to look for the endometrial thickness and to rule out adnexal causes. Then
in ultrasound, you will look for endometrial thickness. So what, how do you measure and what is the cutoff?
Ma'am, in postmenopausal bleeding, the cutoff is 4 to 5 mm. If the endometrial thickness is greater than 5 mm, then it should raise a suspicion of and with symptoms like postmenopausal bleeding, it should raise
4
the
or
suspicion.
5?
Now,
I'm
according
4.
to
Sorry, 5.
ACOG, it's more than 4 mm, and according to FIGO, it's more than 5 mm.
So what is the negative predictive value with both? What is, if you take the cutoff as 4? The negative predictive value is more than 99%.
Okay.
So whichever you take now, 4 or 5. And then how do you measure it? TVS or transabdominal?
Transvaginal scan.
Vaginal. And where should your calipers be?
Ma'am, between the endomyomet on both the sides of the endomyometrial junction.
Have the uterus in the longitudinal axis, and perpendicular to that, you measure the thickest part of the endometrium, right? जो एक heteroic line होगी ना, hyperechoic line, so you will measure in between that. What if you have fluid? If you have pyometric, then how do you measure ET? Your ET, your endometrial thickness is one of the major diagnostic modality, isn't it? The non-invasive one.
Yes, ma'am.
So you should know a little bit more about endometrial thickness. Okay? So you kind of go see pictures, see how they are measuring, what to do if there is fluid inside, because one of the very important thing you said, it could be pyometra, which could be cancer also, or which could be per se a cause of, because of atrophic endometritis, it could per se a cause of postmenopausal bleeding also. So that is one thing. So would you do ultrasound and aspiration, or only aspiration, or both? I mean, what would be your line of management? Pehle kya karoge?
First, we will do the transvaginal scan and we will measure the ET. If the ET is more than 4 mm or more than 4 mm, then we will go for endometrial aspiration cytology or endometrial sampling. We would say endometrial sampling in endometrial sampling.
4 mm.
Sorry, ma'am.
Suppose it is less than 4 mm. Then
if ET is less than 4 mm and the woman is having postmenopausal bleeding, then we will.
You did it, yes, because she had PMB.
Yes, ma'am.
PMB with ET less than 4 mm, then we have to ask the woman to come for follow-up every 3 to 6 months.
Every 3 to 6 months.
And we will reassure the patient.
She also has his high risk factors for endometrial carcinoma, so we will go for
individualize. Like I said, ki negative predictive value to 99% hai. But if she has these high risk factors,
high risk factors as well as
recurrent episodes of PMB, high risk factors, then you will go in for biopsy, endometrial aspirate. Otherwise, if she's just had one episode, has a low risk patient, ET less than 4
then we can follow her up.
We can just put her on follow-up. So now we have this case. Suppose her ET comes out to be, you have the investigations of this patient with you?
Ma'am, we have not mentioned it in the slide.
Okay. Now suppose she had a ET of 6 mm, more than 4 mm. Then what would your line of management be?
We will do hysteroscopic dilatation and curettage.
Directly hysteroscopic guided. Or can
Ma'am, we will do endometrial sampling.
First we will do endometrial sampling.
We will do endometrial sampling.
So you can go in for endometrial aspiration, which is a OPD procedure, requires no dilatation, nothing. So endometrial aspiration ke liye, what do you use then?
Ma'am, we use pipple biopsy for endometrial sampling, endometrial aspiration. We do it in routine OPD procedures. And we can also use office hysteroscopy, which has a smaller diameter and does not require any dilatation of the cervix, and can be performed in OPD procedure.
So generally, तुमने people use किया, suppose. So what is the
Yes, ma'am.
percentage in which it can show as inadequate specimen?
Ma'am, it's around 40 to 50%.
And nobody would be using peoples. अगर आधे patients में sample ही नहीं आएगा तो why use that thing? ना? It's about 8% that you would get, you do not get adequate specimen. तो अगर adequate specimen नहीं आएगा तो of course you will have to go for a hysteroscopic directed
biopsy.
Yeah, DNC. So now you did a peoples. It showed endometrial. Dr. Harsh, आप पूछना चाहते हो? मैं ही बोलती जा रही हूँ.
Yes, I would like to. Yeah, one thing is that if you're doing the pap smear, Rutushree, and it has reported that there are endometrial cells. So she's a post-menopausal woman, right? Is it significant? Is it significant? Is it going to diagnose?
Yes, ma'am.
Yes,
ma'am.
Yes, ma'am. In cases of endometrial hyperplasia and endometrial carcinoma, it might the pap smear might show results as endometrial cells in the sample.
And it is called as atypical glandular cell of unknown significance in.
See, that means if you are finding atypical glandular cells of uncertain significance, first of all, when you are doing the ultrasound, you must see the endocervix also, because it's very important. She's a case of PMB,
Yes, ma'am.
right? And you are finding that Aegis, right? By Aegis, atypical glandular cells, and you are finding that there is growth in the cervix, then the diagnosis will change. It will not be your endometrial cancer. It will become
Yes, ma'am.
cervical cancer.
Cervical cancer.
Endocervix, adenocarcinoma, right? So
Yes,
that,
ma'am.
Yes,
and
ma'am.
in what percentage of the cases, if endometrials are seen, that patient has endometrial cancer?
I mean,
In 20 to 30% of the cases,
29.
it can be associated with that endometrial cancer, right? And secondly, I think Dr. Sangeeta was discussing beautifully about the ultrasound findings. But when you are doing the ultrasound, it's very important what all to see on ultrasound. As I told you that it should be the cervix, it should be the endometrial cavity, and secondly, when you're seeing if there is any growth or this thing, whether the endomyometrial junction that is intact or not. So on good ultrasound transvaginal sonography, you can see that also. And thirdly, that if you are seeing that adnexa is very important, as we have discussed, that there can be this, it can be associated with ovarian tumors, so you must see the adnexa also. So in a case when you are seeing, so these are the factors which can lead to this postmenopausal bleeding. So you must look for all these things when you are doing the transvaginal sonography. Now, Dr. Smita has nicely asked about this thing, how will you confirm your diagnosis? Any other investigations you would like to do?
Ma'am, hysteroscopy directed biopsy.
That you have already, suppose on people we are not sure of the diagnosis, then of course the next step will be that. Is there any role of tumor markers? Is there any role of tumor markers?
Ma'am, CA125, CA125 has a prognostic value. If there is any extrauterine spread, or if there is a higher grade, there is invasive metastasis, then the CA125 can be raised. And this is important in following up the patients with higher grade carcinomas.
This is not diagnostic, but
it is not a diagnostic.
It's a very non-specific marker, because you can't just say that if it is high, yes, if it is more than 100 and you're not finding anything in the ovaries and all, then one can think. And suppose on endometrial cancer we have found on histopathology, then of course it's a prognostic factor, right?
Yes, ma'am.
Now, what all other investigations you would like to do?
Was on ultrasound to find a localized swelling of the endometrium. Then any other investigation you can do? Or you find the endometrium thick? and you're not
Ma'am,
sure.
MRI can be done.
What is SIS? Cis.
Saline infusion sonography.
So what is
It
the
is
role?
especially it is especially useful to detect polyps and any focal endometrial growth like fibroids, but it is not a very good diagnostic modality for detecting endometrial CAs or hyperplasia.
So it's only good if you are suspecting polyps, right?
Yes, ma'am.
So especially if you have a localized thickened endometrium there. And CT
Yes,
MRI, what role do they have?
Ma'am, the role.
Any one of you?
Ma'am, MRI has a diagnostic role in detecting the depth of myometrial invasion, the endomyometrial junction, as well as if there are any other parametrial invasion or any vessels or nerve entrapment is there. And CT has not been found to be so much better, but it can detect lymph node metastasis very well.
Basically, when you have a diagnosis of carcinoma, then you would go in for these
MRI and CT.
Further modalities.
We are still at PMB. So we did an ultrasound which showed more than 4 mm. And this is all hypothetical. So we did an aspiration which showed endometrial hyperplasia. Let's first stick to endometrial hyperplasia. So now, what are the types of endometrial hyperplasia? I mean, what histopath do you expect in endometrial hyperplasia?
There are 4 types of endometrial hyperplasia: simple endometrial hyperplasia without atypia, complex endometrial hyperplasia without atypia, simple endometrial hyperplasia with atypia, and complex endometrial hyperplasia with atypia.
This was by WHO a long time back.
Older classification.
What's the latest?
Ma'am, it can be benign or EIN or malignant according to 2023 International Federation.
तुम तो कैंसर की स्टेजिंग में आ गई 2023. Endometrial hyperplasia generally is RCOG. If you read the RCOG guidelines, or everybody is not taking the classified is into only 2 categories, isn't it? Endometrial hyperplasia.
Ma'am, hyperplasia with without atypia and complex endometrial hyperplasia or atypical hyperplasia.
Hyperplasia, just endometrial hyperplasia and atypical hyperplasia.
Atypical hyperplasia.
EIN, endometrial intraepithelial hyperplasia.
Yes, ma'am.
Generally, now you have only these 2 categories. But 4 categories, those were very high PGDs. Things have changed a little because they saw that these 4 were really not good enough. So now they have come down to 2. Okay, they could never really compare these 4. You know, that is why they have come down to these 2 now. Now, suppose she has simple hyperplasia. Simple hyperplasia, nothing.
Simple hyperplasia. Yes, ma'am. Then we can offer. Then we can offer her Mirena LNG intrauterine system.
We can go on for progesterone therapy. It can be in the form of IUCDs or oral progesterone. In oral progesterone, we give megestrol, either megestrol or medroxyprogesterone acetate. Megestrol dose is 40 mg BD. And medroxyprogesterone acetate, we can give 10 to 20 mg.
Even norethistron, 10 to 15 milligram BD, right? Or you can put in IUS.
IUCD, Mirena.
Mirena, isn't it?
Mirena.
So
Yes,
how
yes,
will you give oral progestagens? How many days in a month? What will you
And we can give.
Patient?
And we can give her for 6 months, and then we can repeat biopsy again after 6 months.
Daily, or she breaks in between, 3 weeks on, 1 week off. What do you write? What do you tell her?
Oral progestins. And daily for
So
6 months.
you just have to think, तुम अगर मिरीना डाल रही हो तो क्या हो रहा है? Continuous daily लग रहा है, मिल रहा है ना उसको?
Yes, ma'am.
So
It is
continuous.
given as daily.
Yeah, it is not 3 weeks off.
Daily
And
for
off.
6
I was
months.
just asking that to throw you off the track. So you should be sure, confident, कि daily देना, without a
Yes,
break
ma'am.
for at least 6 months. Because it's been seen that if you do not give daily, then the regression of the endometrial hyperplasia does not happen. So 6 months daily, whatever you want to give. You want to give NPA, you want to give norethistidone, whatever you want to give.
And what are you going to do after 6 months, Rutushree?
Ma'am, we will repeat a biopsy again to look for regression or
What would you like to
progression.
say? What would you like to say that?
Ma'am, if there is negative biopsy for 2 occasions, then we can stop the treatment.
You did a
6
biopsy
months
after
apart.
6 months, she still has hyperplasia.
Ma'am, then we will again continue the treatment for another 6 months and then we will repeat biopsy after 6 months.
Suppose now after 6 months again there is hyperplasia.
Then we can offer her hysterectomy, ma'am.
Then you have to offer a hysterectomy.
Hysterectomy with bilateral salpingoophorectomy.
The patient is not responding after 1 year. Don't wait any further.
3 consecutive
Yes,
this
ma'am.
thing positive for hyperplasia, I think patient should have the hysterectomy done.
Hysterectomy. Yes, ma'am.
This was for basically endometrial hyperplasia. Now suppose you did this and you found up there was a polyp when you did an ultrasound or you did a hysteroscopy. So now what will be the treatment for this patient? Suppose it was the endometrial polyp which was causing her PMD.
We can go for hysteroscopy and then polypectomy and send it for biopsy.
So polypectomy with the DNC of the rest of the
DNC.
Yes, ma'am.
DNC. Yes, ma'am.
Okay, because many times it can
Endometrial hyperplasia is also associated with polyp.
hyperplasia can be atypical for all you know. So you have to do
Atypical.
a
Yes.
DNC. So you did तुमने polyp निकाला, so the polypectomy shows specimen of the polyp shows atypical endometrial hyperplasia. What will you do further?
Then we can offer her hysterectomy, ma'am, with hysterectomy with.
You remove the polyp.
Ma'am,
Ma'am,
progesterone therapy देंगे मैम. अगर polypectomy, if we have already done the polypectomy and in biopsy.
Polypectomy करके इसके histopath में आया atypical endometrial hyperplasia.
Atypical hyperplasia is associated with 29% risk of development of endometrial CA. That is why we will not give her oral progesterones or systemic.
Because
we will offer her hysterectomy.
Would be associated with endometrial cancer.
Cancer.
So if even if you remove the polyp, you will still go in for TH with
hysterectomy.
Yes, ma'am. She says, and in case it was on your endometrial aspiration, it is atypical hyperplasia, so you'll go in for?
Then also go ahead.
Right?
TH.
BSC. What about lymph nodes?
Ma'am.
Ma'am, in atypical hyperplasia, we will not remove lymph node.
Yeah. So there is no role of
in atypical. Yes, ma'am.
Hyperplasia. This is hyperplasia, right? It is still not cancer.
Yes, ma'am.
Lymphadenectomy in these patients. Now then, suppose you have a woman who has not completed her. Let's leave it at that.
Suppose she is less than 40 years of age. Let's go in that. Patient is less than 40 years of age and she wants to complete her family. She wants to produce another child. And you find that there is atypical hyperplasia. So how are you going to manage this patient? This is what
we can give her hormonal therapy.
Hormonal
we can offer her hormonal
Tell us
therapy.
What?
Ma'am, we can give her oral progestagens only in the form of medroxyprogesterone acetate, megestrol acetate, or Depo-Provera injections.
Is there any
After
role of IUD, LNG IUD?
Yes,
Ma'am,
ma'am.
if she wants
Wants
fertility, then
fertility,
IUD will
then
not.
that is.
We will not put IUD. We will only give oral progestins.
Maybe for the time being, it becomes normal. So I think it will be better that instead of putting her on oral medication, LNG
Oral
IUD
medication.
will be better.
Yes, ma'am. If she wants, if her family is complete, then we can offer her IUD also.
No. We are not talking about family complete. She wants a baby. If the family was complete, we would have removed the uterus.
Yes, ma'am.
She is desiring fertility. So that is why we are putting her on progestogen.
Yes, ma'am.
Yes,
So she
ma'am.
should not be conceiving till her hyperplasia has regressed back. We have to make sure of that. So once her hyperplasia has regressed back, only then can she, like if you have a patient with atypical endometrial hyperplasia, how often will you do her endometrial aspiration? 6 monthly?
6 monthly, ma'am.
And these are the ones who 30% will go on to have cancer, no? Inka you do 3 monthly.
3 months. Okay.
The definitive treatment is surgery. You are not leaving these patients on medications at all. But because now
Yes,
she
ma'am.
wants a child, so you're leaving her on progestogens. But then you need to do endometrial aspiration after 3 months and see. Now, if after 3 months she has regressed to endometrial hyperplasia, I mean a normal endometrium, then please tell her to try to conceive now. And it's always best that they go in for assisted reproductive techniques.
Yes, ma'am.
Leave them for natural conception, which might take how many months you don't really know. So here is a patient, you don't want to let her carry on with a atypical hyperplasia for long. So they you generally advise them to go in for ART, conceive fast, and then have your uterus removed.
Removed.
Okay. What next? Next would be, so the most common, of course, in these cases, the most common cause of PNB क्या है? हम तो hyperplasias में आ गए.
Atrophic
Ma'am,
endometritis.
atrophic endometritis.
Endometritis, है ना? Which is seen in how many percentage?
Ma'am, almost
Close to 60 to 70% is atrophic endometritis. है ना? Hyperplasias and cancers तो 10% में होते हैं. It is mostly benign. So why does atrophic endometritis cause PNB?
What does the estrogen deficiency cause? Now tell us about the vaginal cytology. Rutushree?
Yes, ma'am.
Hanji.
It's coming.
Why does atrophy occurs?
Estrogen क्या करता है?
Ma'am,
Cycle में क्या?
endometrium, it reduces the layer of endometrium, the glands, it decreases the blood flow to the glands, because of which the there is necrosis, ma'am. That is why it leads to PNB. Due to less blood supply.
Estrogen कम है तो your blood vessels are all collapsed. Microabrasions होते रहते हैं. Microabrasions होते तो उससे chronic endometritis हो जाता है. Chronic endometritis से spotting happening after marriage. Vessels also are very superficial, so they also ठीक नहीं हो रहा ना तुम्हारा. तो जैसे endometrium, estrogen क्या करता है endometrium को? In the proliferative phase, what is it doing?
Estrogen proliferation करता है, मैम. Proliferate करता है.
Chat box में आ रहा है, can't hear.
अच्छा. Whom can't they hear?
I think I can to hear.
I don't know.
Hello?
No,
Yes, ma'am.
only 4 of us can hear.
क्यों किस किस को सुनाई नहीं दे रहा डॉक्टर माला?
Ma'am, it is
Chat box में
audible,
किसी
ma'am.
ने
It is
लिखा है
very
मैम.
much audible.
Chat
It's
box
not
में
audible.
someone has written can't hear.
So I think
Silky
वो देख ले
Jazoria.
अपना कि unmute करे अपना. बाकी everybody can hear? Only one person cannot hear.
I think so I don't know. Nobody is responding.
Hello, can you people hear?
Audible लिखा है.
Yes, ma'am, it is audible,
Audible?
ma'am.
Huh?
Yeah, ma'am.
So something
Yeah, ma'am,
wrong
please
with the
go ahead.
person who cannot hear, I think.
So where were we? We were on hypoestrogen.
Atrophy, high student.
Basically, estrogen is making your not helping in the endometrium to grow. The vascular, when your endometrium is all perfect, your vessels are all superficial. Once the vessels are superficial, there are always micro abrasions happening because the wall is collapsed, uterus key. It is so thin and atrophic. So they rub against each other, you have micro abrasions happening. So they cause spotting. And micro abrasions also lead to chronic endometritis. That again causes spotting. And that is why you have postmenopausal bleeding happening in these women. Okay? So that is one of the reasons.
And in postmenopausal patient, if you are taking the pap smear, it's very important that suppose the report comes that it's not significant and report is not, you can't see any cells, endocervical cells are absent and vaginal. So what should you do?
Ma'am, we should repeat the
Pap smear after giving what?
estrogen therapy, ma'am.
Oral or vaginal?
Oral and vaginal both can be given, ma'am.
Vaginal will be better.
Vaginal is
Okay,
better.
just to regenerate the cells. Right?
Yes, ma'am.
What about tamoxifen? We've not touched that. Tamoxifen is generally used by
breast cancer
Ma'am,
patients.
breast cancer patients.
But only if tamoxifen is given for more than 5 years, then it increases the chances of endometrial cancer.
And suppose you have a patient of tamoxifen and her ultrasound was done like it is done for following these patients. Her endometrial thickness was 8 mm. Now what will you
Ma'am,
do?
even if she is on tamoxifen and she does not have any symptoms, then we will not do any sampling, ma'am.
That is very important. There is no ET cutoff for patients on tamoxifen. So if they are asymptomatic, you don't need to do anything. Only if they come to you with, again, PMB, with bleeding, then you need to, of course, sample them. Because then they anyways are prone to hypoplasias and atypical endometrial hypoplasias later on. So that is one very important thing to know.
I just want to add that this tamoxifen, when it is given, it just causes the edema of the endometrial cells. That is all. That is why you find that the endometrial thickness is more.
And even SIS, saline infusion sonography, is very good in patients on tamoxifen. Because patients on tamoxifen generally have subendometrial cyst. When you do a cyst, so you can actually make that out very well. So one of the important role of cyst is in patients on tamoxifen. That also.
What is the cutoff level for the tamoxifen patients for endometrial thickness?
Ma'am, it is greater than 10 mm with postmenopausal bleeding.
11.
Without also. It is still 12 mm. Right?
Yes, ma'am.
I think mostly we've not covered endometrial cancer in this.
Now, can you tell us about the further management of this patient? Now, suppose in this patient you have done the hysteroscopy DNC and there was no polyp passage, there was this thing, you could see a growth and the report comes as CA endometrium. So how are you going to proceed further?
Dr. Mala, tell us when to stop.
It's your choice, and this.
We are the last one, so we can
Yes.
carry on.
So it's your choice, because basically we have to discuss.
Last two questions. Chalo, batao.
Yes, last two questions.
I think Sumita, now you ask.
So now you did a biopsy. It shows
Yes, ma'am.
metroid grade 1.
Which grade? Yes, ma'am. Histologic grade and type of cancer. It depends on the
I'm telling you,
histologic grade and
grade
type
1
of cancer.
endometrioid.
Ma'am, grade 1. Grade 1 endometrioid, then we may go for extrafacial hysterectomy with bilateral salpingo-oophorectomy. There is no such indication that we should do lymph node dissection.
First, do a MRI to see for myometrial invasion.
Yes, ma'am. We will.
Stage.
MRI. Yes, ma'am.
Yes, ma'am. MRI evaluation to see the myometrial.
ये तो तुम्हारी endometrial biopsy में report आई है ना. So you still have to see. You have to classify her. So you did a MRI which showed myometrial invasion less than 50%.
Yes, ma'am.
It's just some invasion in the myometrium. So she becomes which stage?
Stage 1A.
Stage 1A, 2.
According to 1A2.
1A2.
1 according to modified FIGO classification 2023.
3.
She becomes stage 1A2. So treatment would be?
Extrafacial total
hysterectomy.
salpingo-oophorectomy.
What about lymph nodes? Lymphadenectomy?
In stage 1A, 2.
If the size of the lymph node is less than 2 mm, then we don't do. If it is more than 2, then we go for pelvic lymph node dissection.
Lymph nodes, though, we don't know. You are doing surgery now, isn't it? You don't know whether the lymph nodes are there or not. They were not picked up on CT scan.
And there is no role of lymph node dissection in low-grade tumors.
Yeah.
And
so what
especially
low-grade tumors?
low-grade tumors constitute of grade 1 and 2 endometrioid carcinoma without LBSI and no lymph node positive without LBSI.
When you're doing surgery, you can see the size. So if it is less than 2 centimeters and you
Less
have
than 2 centimeters.
in grade 1 or grade 2 endometrioid, so these are low risk. So in them, lymph node mets is less than 5%. So you do not go in for lymphadenectomy. So suppose you were really not sure, then what is last question? Sentinel lymph node biopsy.
Ma'am, according to FIGO staging 2023, lymph node sentinel lymph node dissection is advised for intermediate, high, and high risk patients for endometrial carcinoma.
So what are the sentinel lymph nodes in endometrial cancer?
Ma'am, these are mostly the pelvic lymph nodes, and
all pelvic. Sentinel would be one group, isn't it? Sentinel is the first group of lymph nodes in which you would have mets. So that if they are positive, you know that there are mets all over and you would do a lymphadenectomy. And if your sentinel lymph nodes are negative, you know that the rest of the lymph nodes would be negative.
Are not affected.
Which is the first set of lymph nodes which would become positive in endometrial cancer. Pelvic
external.
Internal, external.
Externally.
Yeah. So तुमने flu it is the external iliac. So the
external iliac.
External iliac or the obturator, not the internal iliac or presacral.
Yes, ma'am.
That is one option which you can do. Then you were talking about LVSI. What is LVSI?
Lymphovascular space.
Ma'am, lymphovascular space invasion. That is more than 5 vessels which have been involved. Then it is significant lymphovascular space invasion. If less than 5, it is not that significant.
It's called focal if it is less than 5, and if more than 5, then you call it as significant LVSI.
Significant, yes, ma'am.
LVSI देखते को कौन सी vessels देखते हैं tumor? Which vessels are you seeing in LVSI? Basically, the vessels are there at the growing edge of the
Yes, ma'am. The atypical vessels which are present in the
Those are the vessels that you would be seeing.
tumor.
Okay. I think we can close it. It's already 8:20.
So I must thank all the PG students who have presented the cases and all the moderators who have taken their exams and guided them and given great scientific inputs. I must thank our chief guest, Dr. Kamal Bakshi, and our guest of honor, Dr. Rajendra Singh Pardesi, and all the moderators, starting from Dr. Kamal Gujral, Dr. Abha Singh, Dr. Geeta Mendiratta, Dr. Jayashree, Dr. Karishma, Dr. Radhika, Dr. Shashilata, Dr. Sunita Lama, Dr. Sheila Mane, Dr. Shailesh Jain, Dr. Supriya Jaiswal, Dr. Rahul Modi, Dr. Seema Singhal, Dr. Helen, Dr. Archana Mishra, Dr. Chandra Mansukhani, Dr. Nalini Arora, and Dr. Dipti Goswami, Dr. Reema Bhatt, Dr. Aparna Sharma, and Dr. Sangeeta Gupta, and of course, our own teacher, Dr. Harsha Khullar Madam, Dr. Sumita Mehta, and I think Dr. Archana Dwivedi did not join. And I congratulate all the students, starting from Dr. Smriti Gupta, Dr. Aarti Trivedi, Dr. Nikita Sharma, Dr. Nikhil, Dr. Khadija, Dr. Aarti again, Dr. Preeti, Dr. Smriti again, Dr. Arzu and Dr. Anusha, Dr. Sreeba, Dr. Pragya Pandey, Dr. Payal, Dr. Maria, Dr. Rutushree, and again Dr. Maria. So they all have really worked hard. I must congratulate and compliment all our PG students who really worked hard. And I thank all the teachers and the moderators who've taken time out of their busy schedule to guide our students. And I must thank Dr. Ila Sharma, our Master of Ceremony, and Dr. Huma Ali, who sat through and saw that the program was done seamlessly. We meet again tomorrow at 9 a.m. and that will be our third day of the Gurukul classes. And I'm sure all the students will highly benefit from these 3-day program. Thanks everyone. Good night and goodbye.
Before we conclude, I must say, Dr. Sumita, please grade our students who just presented. Dr. Sumita, you are still there?
I'm there. Both Rutushree and Maria did well. Their history was complete. Hardly 1 or 2 points. Examination, I mean, you took all the relevant negative history, which is really good. That means you had all these differential diagnoses in your mind, which you were checking out. And the examination again was complete. So for those, I would score you out of 5, maybe 4. Very good history and examination. Now, once you have the investigations and things, then we go further. But thoda what you really need to impress upon is ultrasound. Very important for PMB. You have to know how this is done. Just read about it once. Then even endometrial aspiration, because these are the 2 cornerstones now of our diagnosis. TVS and endometrial aspiration. Endometrial aspiration may be bahut kuch hai. You have low pressure aspirators, you have high pressure aspirators. High pressure aspirator में हम Carmen's use करते हैं. Low pressure में हम हमारा Peoples और
use करते हैं.
तो थोड़ा सा इनके बारे में और डिटेल में पढ़ो. Otherwise, you will pass with flying colors.
Thank you, ma'am. Thank you,
Thank you,
Sumita,
ma'am.
for joining. Thank you.
Okay, bye-bye. Good night.
Bye. Good night.
And all the delegates, all the students who have joined, PG students who have joined as delegates, I must thank each and every one of them. And I must thank our back-end people, Mr. Vinod and Mr. Prakash and Ritu Parna from the ClearNet, who has given us this platform for seamless continuation of the program that we had, virtual platform. Thanks everyone. Good night and goodbye.
Good night.
Thank you.
चलो